Good afternoon, ladies and gentlemen. Welcome to the much anticipated event CUBE HDMI 2023. I am Kshama Nandode, Senior Marketing Manager IVD, Mindray, and I am thrilled to be your host for this extraordinary gathering of minds and innovation. Today we are diving into the future of technology, and I guarantee you a day filled of excitement, inspiration, and groundbreaking discoveries. As we bask the glow of the ceremonial lamp lighting, it is now my distinct pleasure to invite a remarkable individual on the stage, a person whose wisdom and guidance has been instrumental in making this event a reality, without whom I should say it's impossible. Please join me in welcoming Dr. Anil Handu to the stage to deliver his welcome speech and officially kickstart this event.
You know, this is the 6th edition of CUBE. The idea is that we will learn and teach at the same time. And this is one unique forum where everybody comes with something to share. Not only, the things that they have done with their analyzer, but also with something that they have found a difficulty to handle. And I think that has really made this event something which most of the people look forward to, especially the ones who are in the area of hematology analyzer science, if I may say so. I'm sure if I tell you the reality of this whole thing, I think Ramon, Simon, and Sukesh Nair sir, they were the ones who actually initiated the whole process. And of course, at that point of time, it was never called CUBE. It used to be called VCS once upon a time. And we took over from them and we decided that we will keep the light on and ensure that it keeps going on and the analyzer science is actually, taken to the next or the newer heights. Thanks to both of them, who actually helped us to initiate the entire process. We are here today and we're all sharing our information, knowledge, and at the same time wanting to learn more. And we always say, never say goodbye, always say, the next CUBE is on in 2024. And I'm sure after you finish 2 days of deliberations today and tomorrow, we'll meet yet again in 2024 in some other place, in some other way, and share all our knowledge between all of us. Thank you very much, ladies and gentlemen, for being with us, for sparing your time for these 1.5, 2 days. And all those live audience which is there online with us, there are nearly 2,700 people who have actually registered for the event, and I'm sure as the event unfolds, a lot of them will be actually online. And I really promise you all that you will go back with a lot of information and knowledge which will help you to make it better with each passing day as far as the analyzer science is concerned. Thank you very much. Have a good day ahead.
You have undoubtedly set the tone for what promises to be an extraordinary event. Thank you so much for being our mentor. Without further ado, I would like to invite Mr. Sudeep Mukherjee, Deputy Director, IVD Mindray India, whom we amicably call Dada, to grace our stage and deliver a few words of wisdom and inspiration.
Thank you, Dr. Handu. Very good afternoon, ladies and gentlemen, all doctors, participants, and the entire healthcare fraternity. I'm truly delighted and honored to stand here before you today as we kick off this extraordinary mega event, CUBE HDMI, on behalf of Mindray. I extend a very, very warm and hearty welcome to each and every one of you. I'm Sudeep Mukherjee, Deputy Director of Mindray India, and I'm privileged to witness the incredible talent and dedication that our team brings every year. Well, this is a blockbuster event in hematology, which was started long back in 2018. And Mindray India feels proud to host this along with BLK Max every year. This is the 6th consecutive year that we are hosting this event, and I convey my sincere gratitude to BLK Max and especially Dr. Anil Handu sir, under whose guidance and leadership this whole event is being organized. We are very much pleased to welcome and thank Dr. Ramon Simon Lopez, who has come all from Barcelona for his presence in this occasion and to bless us and enlighten all of us with his profound knowledge. Thank you, Dr. Lopez. Mindray has always stood at the front of healthcare innovation. We are dedicated to advancing healthcare for humanity. Our commitment to quality, innovation, patient-centric and user-centric solutions has actually propelled us ahead. We are now one of the global leaders in providing medical devices and solutions. Mindray has its presence, in more than 190 plus countries with more than 300 different type of products. We are always committed in providing advanced technologies and transfer them into innovation, and then when we make it accessible to the larger part of the world. We are now in leadership position in various segments in India, and I'm proud to say that we have acquired number 2 position in hematology worldwide as well as in India. Mindray India started its operation in 2007, and over 15 years we have excelled, in the Indian market as a market leader, and established our presence as provider of medical devices and continuously serving the healthcare industry. Well, we are not only known as manufacturer and marketeers for the medical devices, but we are also known for imparting knowledge to the fraternity through various seminars, CMEs, and scientific events like this. One of them is CUBE, cytomorphometry, unveiling blood evaluation, which is a true academic scientific event wherein omniscient pathologists from all over the nation as well as international participants, they reach us, they join us to enlighten us with their knowledge. During this 2 days mega event, various cases in hematology are discussed to aid everybody in the clinical utility of the novel parameters with the profound knowledge of the eminent speakers. I sincerely urge everyone to hold back for these 2 days scientific feast and gain as much as knowledge and which can further help you in day-to-day practice. Thank you once again for being a part of this mega event, and once again extend a very warm welcome to all the delegates. Thank you.
Mr. Mukherjee, your words have touched our hearts and set the perfect tone for this remarkable gathering.
Thank you.
Thank you
Shama.
so much. Before we embark in our journey ahead, I have an exciting announcement to make. So hold on, ladies and gentlemen, esteemed guests, and fellow enthusiasts in the field of hematology. In our ongoing pursuit of advancing knowledge and facilitating collaboration, I am thrilled to announce the launch of a very exciting thing which will happen in a few seconds from now. So may I call upon stage Dr. Anil Handu to do the honors, please. Yes, sir. You have to touch there and see the magic. Oh,
What happened?
so once more, please. Oh, so you press that A. Let's see. Oh, something wrong, Suganya? How's that? So may I call upon stage Dr. Ramon Simon, please. I'm thrilled to announce the launch of our CUBE website on this day today, on which we were working sincerely. And the man behind this CUBE website is Mr. Nikhil Panjwani, our Marcom manager. So please, a huge round of applause for him. Unparalleled insights into hematology, now a click away. So it will serve a hub for the latest updates, research findings, educational resources, and a platform for networking and sharing knowledge. So without further ado, I call on stage our first speaker of the day, Dr. Anil Handu. We are privileged to have him as our first speaker, and I have no doubt that this lecture will leave us enlightened and inspired. To chair the first session of the day, may I call upon Honorable Dr. Das Gupta, a very well-known name in the field of hematology. He has 4 decades in-depth experience in hematology and leading medical institutions in India and abroad. Who does not know Dr. Das Gupta? Dr. Das Gupta's areas of expertise include interpretation of bone marrow smears and biopsies, flow cytometric immunophenotyping of hematolymphoid neoplasms, including measurable residual disease and other flow cytometric assays. Diagnosis of hemoglobinopathies, including newborn screening, investigation of chronic anemias, thrombophilia testing, and diagnosis of platelet disorders. Dr. Das Gupta has published more than 135 scientific papers in peer-reviewed international and national journals. He was a teacher and guide to many MSc and PhD students at the Mumbai University. May I request Dr. Das Gupta to introduce the first speaker of the day? Thank you.
Thank you, Shama, for your kind introduction, and thanks to Mindray for this fantastic opportunity to be here with all of you. I was kind of unlucky to have missed the previous ones for one reason or the other, although the Mindray colleagues have been connecting with me every year to see if I can join, and it's indeed loss on my part that I have not been able to be part of this fantastic activity that India conducts every year. When we talk about the development and growth in hematology, CBC is a very basic or very fundamental investigation, and it has been there for now decades. But it is also very fascinating that with advances in technology, in electronics, computer science, and things like that, the art and the science of doing cell assessment, blood cell assessment, has also evolved. And the fact that today we are having a forum like CUBE, where we mainly discuss these aspects, itself speaks a lot about the way science has moved, even in this area which otherwise is considered to be mundane. But I think all of us who are in this field will realize that every patient's journey in the process of management starts with by and large, a CBC. And in fact, this is one of the most common or commonest investigations that a patient undergoes. And there is a huge amount of information available in the data that we generate from these analyzers, and it's very challenging for all of us to decide about, and more so for people who want to go for hematology analyzers to decide which one to go for, because the advancements have been really phenomenal in all the brands. And of course, Mindray is a leader, as was mentioned by Shama, in this field, or Dr. Mukherjee mentioned that. So without wasting any more time, I would like to invite Dr. Anil Handu. He has already been introduced, and he, as you know, has been the main force behind these various organizing of these sessions. Dr. Handu is at the BL Kapoor, and again, he doesn't need any introduction. I feel privileged because he is a young colleague of mine and we interact very closely on many fora. And it's indeed a pleasure to welcome Dr. Handu to deliver his talk, and we look forward to hearing you, Anil.
Thank you. Good afternoon, everyone. And since I'm the opening batsman for the entire activity, I deliberately chose this topic. Now, when I talk about any cell in hematology, which cell do you think is the most glamorous cell? It's the lowest in number, but the highest in glamour because it's the most colorful. And what defines hematology? All sorts of colors. So I thought, let me just talk about something, because if I keep giving you what what we do in our lab and, give you the data, that all of you are anyways going to share with us. So I just thought, let us look at this glamorous cell, how it evolved over years. In fact, the history is almost more than 100 years old. So if I start with my talk, this is the place where I work, and I bring you warm regards from my Institute of Laboratory Medicine, BL Kapoor Hospital, and this is my lovely team, which works at the back. And of course, I don't have any significant disclosures to make except that this is a forum of Mindray on which we are playing the entire activity. Now, do you know, this is one activity which small kids do at school. I don't know how many of you have been through this activity with your kids, but they make them create a system wherein they are able to actually differentiate the coins in terms of their size. And this is one activity which a lot of people have done, at least I have done with my son many years ago. And I was very thrilled to understand it because I eventually collated it and tried to look at it from the WBC's point of view also. And if you look at impedance, that's what the instrument does. Now, historically, the WBC counts have been measured manually. And nothing has changed so far, by the way. A lot of people think that there is a standard methodology of WBC counting, and by the way, the standard methodology, even today, is a manual WBC count. So there's a lot of work which is currently going on flow cytometry, but we still do not have the exact standardized flow cytometry-based method. So there are lots of terminologies and techniques which are used for WBC counting today, which is electrical impedance, force volume, radio frequency conductivity, light scatter properties, and of course, use of dyes, which eventually give you cytochemistry. And of course, we talk about 5-part differentials, and people talk about 6-part and 7-part and 10-part, and I'll not get into details of that, but that's something which a lot of people discuss about, and all this is based on all of these techniques. Now, I told you historically, cell counts, especially the WBC counts, are still done manually, right? Using what? A hemocytometer. And if you look at the hemocytometer, eventually on a peripheral blood film also, you look at these kind of images which come onto your slides and you're able to count them. And again, these are arbitrary counts, which we all do. But I hope all of you have seen this image or dealt with this particular chamber sometime in your lifetime. At least in MBBS and MD, they would definitely want us to do this. A Newbar's chamber counting, and of course these corner squares. And then most importantly, we were using what was called the WBC diluting fluid, right? Now, I'm sure all of you must be wondering, I'm supposed to talk about analyzers, but here I'm standing in front of you and talking about WBC diluting fluid, manual WBC count, as to why am I even discussing it as on today. So I'll come to that in just another, maybe a minute or so. Just look at the constituents which you have here. You have glacial acetic acid and distilled water. You have gentian violet. And of course, you are also maintaining a pH at a certain point, right? This is what you're doing when you are doing a manual white blood cell count. And of course, when you do that, you charge the chamber and you count it in the grids. Again, no rocket science. This has been there for ages, right? Now, do you think this is any different in an analyzer than what you're doing here? The honest submission to that is the entire activity is almost similar. So you have a chemical reaction. What is the chemical reaction? You have a lysis, you have stabilization, you have permeabilization whenever you use a dye, and obviously in cytochemical analyzers you have cytochemistry. But all this needs to happen quickly. Now, if I give an analogy to cooking, whenever you try to cook, what do? You either increase the pressure, put it in a pressure cooker, or you heat it up. right? This is what you do. So let's do that. We heat it up, we put it under a lot of pressure, and all these reactions happen very quickly, and then we visualize it. How do we visualize it? We go to the current or a frequency or the light scatter, and any of these is eventually going to give us a digitized scatter plots and histograms. So from the manual counts to the automated WBC counts, it is nothing but a tiny journey of just adding pressure and temperature to it and making the reaction happen quickly. And that's how the entire process has evolved. So this is what the automated counting has been. You evolved from a classical impedance-based counting where it was depending upon the size of the cell, you were able to differentiate them and place them accordingly on a histogram. And subsequently, we know the Coulter principle, so I'll not get into details of that, but we also know the fact that every time the cell passes in through the aperture of the analyzer, it impedes the passage of the electric current and gives you an impulse, which eventually is taken on the graphic patterns and you're able to get your counts. Now, when we look at chemical reactions which happen in a classical three-part analyzer, essentially what you have a chamber, you have lysing agents, you have diluents, and you have cleansers, right? Because you have to clean it up. So for all practical purposes, you're adding the WBCs, you have two channels, the hemoglobin and the RBC channel, and you also have the diluent which is coming in, you have the lysis solution lysing the red cells in the WBC chamber, and from there eventually the counts come up and you're able to pick up your graphic patterns, especially again based on a classical Coulter principle which has been in existence for quite some time. And this is the classical graph which comes in front of you. Now look at the five-part of it. What happens there? Everything is virtually the same except that in some of the analyzers, we are now adding a fluorescence light or a different set of reagents. For example, we add a dye, and in that dye, we are differentially actually staining a particular cell and removing the others from the analysis. And then we get a baso channel wherein the lysis of the basophils will happen. You're able to get them separately as well. Again, in staining process, you can stain eosinophils separately, and this is what happens in the eosinophils, and you're getting all of these differentials differentially. There's also a concept today where they talk about instead of using a monochromatic laser light, use polychromatic light. Why does it help you? The polychromasia of the light itself gives you a lot of advantages in terms of picking up a lot of other information which can be there, and this is present in some of the analyzers. And who will forget this part of it where we use actually the cytochemistry to determine a different chemical analysis which is happening within the WBCs. For example, the myeloperoxidase stain, which is otherwise used on a slide, you can use it in the instrument. For example, the instrument which was prevalent all the while and now has been taken out is this analyzer from Advia, which would give you the peroxidase staining. So if you look at automated differential counting today, right from the differential counting using the impedance like the direct current, you would use radio frequency, you would use impedance, you would use laser light scatter, the polychromatic light scatter, the peroxidase chain reactions. You will also look at various channels defining whether you can pick up your nucleated red blood cells. The cell-specific lysing agents can be used. And again, differences in the temperature and the pressure that you use within the chambers will actually ensure that you're able to get the information as quickly as you can. Just to give you a quick recap of how the whole thing works, radio frequency conductivity is primarily the one which is used on the Coulter principle. The cells will pass through, and these pictures are classically from a classical Coulter counter from where the radio frequency, the conductivity, the volume conductivity, and the scatter would be used. Of course, they would also give you a typical scatter patterns which would differentiate the cells into different places. Added to it, the moment you add a light scatter, you would be able to get your scatter plots in a different analyzers at different places. And again, this is nothing but use of flow cytometry to differentiate cells at various sites. And when you do that, you can add cytochemistry, which I showed you previously. The moment you add cytochemistry, you're adding a differential within the counting of the WBCs and able to get your cells differently. For example, the ones which are not stained, you take them as large undifferentiated cells and are able to get you better information. So these are various plots which I've taken from various presentations just to show you and illustrate how the whole thing works. Of course, the fluorescence flow cytometry, which has been in vogue for quite some time. And of course, the cells, the way they come and present in front of you, all of these are also seen. You have the one which is on the left-hand side there, what is called the cube, the three-dimensional view of the cells, and basis that you're able to give what the different cells are. For example, if you look at this particular case, you're able to see very distinctly a green population, which is very big and larger one compared to the rest of the cells. And on the cube itself, you're able to identify them differentially, falling in a certain specific sequence in terms of the X, Y, and Z axis. and this was a classical case of CLL. Again, I'm sure a lot of you would have worked on this. This is something which comes in a classical figure of 8 appearance, which you see on WBCs, especially in cases of dengue. My colleague, Dr. Tina, had done some work on this previously, which we've presented in some of our previous conferences of CUBE as well. And of course, you all immature channels where you're actually going to get your immature counts. For example, the IG ratios or the IT ratios, which you would be talking about previously on the smear, have now been automated, and you're able to get your immature granulocytic counts from various analyzers, depending upon how much of immaturity is there. And you're also able to get what is called the nucleated red blood cell counts, as you can see in this particular analyzer pictures, which are coming from one of the Mindray analyzers. This is another thing which unfortunately did not really find its way a lot, and this was use of monoclonal antibodies for identification of various cell types. And this was primarily done by a company called Abbott, which was giving us an instrument called Celldyne, and in that, they added these CD4, 3, and 8 antibodies to identify T cells. In fact, it was shown that it gave a beautiful correlation with what was available on flow cytometry in these cases. And unfortunately, it never found its way in the real life. So I think with that, I have set the ball rolling, and I will quickly move on to my summary and conclusions. The automated analyzers here today are here to stay. We know that. We have been working on it day, right, left, and center. And we know that we are looking at WBCs from a standpoint where we are getting more and more information from them. In terms of the problems which we have on the hematology analyzers, I don't think the neutrophils and the lymphocytes do have any major challenges, especially in the normal regular samples. But yes, we do get problems when we are trying to pick up basophils versus monocytes and eosinophils. Of course, the basophils happen to be the worst. And there seems to be some thought process differences between us when we look at monocyte coming from an analyzer A versus a B. And we start thinking, oh my God, this monocyte count is wrong and that monocyte count is right. But if you do a head-to-head comparison, you'll realize that even between them, the R values remain very good. And of course, understanding your analyzer becomes very important. Most of us don't even look at the graphic data which comes out and are not able to understand how the graph is actually, kind of conversing with us and telling us what it is all about. If we start looking at that from that standpoint, that yes, I'm going to look at the data in a more pragmatic manner and trying to pick out information from there, a lot of disease states can be picked up from the data coming out from the hematology analyzers also. Additionally, we know that there are lots of newer parameters which I just touched upon in some of my slides where I showed that you can have immature granulocytes, you can have some other newer parameters, like the granularity index or the lymph index and stuff like that which can come up. We also know about the research parametric data which has been evolved so much in majority of the analyzers and has started giving us information directing towards a disease state. So if you look at all this information coming up in such a big way, I think the glamorous cells are becoming more glamorous by the part of the day, and hopefully we all start utilizing this information more and more. And as we deliberate for the next 1.5 days, we'll realize that a lot of work has been done in these areas which gives us information which is phenomenally good. With that, I would like to thank all of you for giving me this opportunity, and I would like to thank my team for supporting me all these times to ensure that we are able to deliver the information and hold these meetings as we have been. Thank you very much, and we look forward to any questions if there are for this talk.
Handu, for tracing the history of WBC counting on the analyzers in a short span of time and beautifully doing so. And I'm happy that you also mentioned about the immunophenotyping as an additional parameter, which was very exciting as a thought. But somehow, as you rightly mentioned, it has not kind of taken shape yet. Although on a day-to-day basis, we all work in flow cytometry. We know how SSC versus 45 gives you a beautiful separation of all the various subpopulations. And you can use that to, kind of extrapolate and find the cells in these various regions. The other thing I just wanted to highlight was that when you are talking about these changes or the morphological differences, we are talking about fresh samples. And a lot of us work in distant testing scenario. Even in hospitals, there can be older samples. And those do impact the, the outcome of analysis more so in the white cell population. Say, for example, you will see that the monocytes will disappear. They'll go and sit in the granulocytic region in the scatter plots, and you get a low monocyte count when you have an older sample. So these are things which you learn along the way. And people who work in these areas, they need to be aware of these fallacies. Otherwise, you tend to give wrong, counts. And at the end of the day, of course, hematology analysis will give you a clue. That is not the end of the story. You will definitely, based on the flags and warnings, you will like to make smears and have a look at the smears and come to a final conclusion, because you can't really make a diagnosis of a disease just from the hematology analyzer data. So that's a very important point for us to remember, because that is not, I don't know, at the end of the day, maybe once we have intelligence going to a level where they incorporate many more parameters and they are able to also give us much more informative differential diagnosis kind of a scenario. But anyway, so thank you,
sir.
Anil, for an excellent talk.
Thank you.
And if there is any one or two questions, then certainly we would like to entertain that and then maybe move on to the next presentation.
How much old sample will give a good reticulocyte count on the cell counters?
Look, I mean, this is a very, very tricky question to answer. In any case, we know that reticulocytes, even if they are kept in a sample, they will mature over the next 1 or 2 days. So for practical purposes, I would prefer to run my reticulocyte count on the analyzer as quickly as I can. But on a reasonable, kind of scale of error, if I may say so, I think probably about 8 to 10 hours should be a reasonable point of time, but not beyond that, because the moment you go beyond that, your reticulocytes will mature and you will not be able to get majority of your proper reticulocyte count, irrespective of whether you do it on the smear or you do it on the analyzer. The quicker, the better, as sir also already mentioned to you.
In fact, since you talked about aging of cells and the impact, and that's a very important area to look at. You may be aware that in certain analyzers, the mean cell volume tends to increase after 8 hours of aging. And these are the analyzers, I don't want to name, you will be able to guess, wherein they use detergents to take care of the poikilocytosis, as they call. But I'm not sure why should that matter to that extent. But in the process, what happens, if you have done some studies and published that as well, that when the sample stays at room temperature beyond 8 hours, you can see exponential rise in the mean cell volume. And you can therefore imagine the impact of that on the diagnosis of a case where, suppose this was a case of microcytic anemia, and you waited for 24 hours, 48 hours, the MCV goes to in the normal range. So you have already missed the diagnosis of microcytic anemia, which is very easy to make on a hematology analyzer if it is properly done. So these points are very important, and I would suggest that you should validate. I mean, at the end of the day, when you run a lab, you must validate the things that are told to you. We do not start a test and offer it to the patients till we have validated it in the lab, isn't it? So I think these points, like the question on reticulocyte count, Anil said the correct thing. I mean, these are cells which are dynamic, they mature, continue to mature. So depending on where you started, you will lose reticulocytes if you wait beyond a certain point. So I think 10 hours is a good time frame within which you should do the CBCs. Max 24 hours, not beyond that. But again, I don't want to get into that. I have some experience of this area, so I tend to get, tempted to get involved in that, but I don't want to continue anymore. So
and of course, keeping the temperature also in mind,
yeah,
the kind of temperatures that we work in, that's also extremely important in this whole scenario.
He is an MDA from Maulana Azad Medical College, New Delhi, and has done some courses in clinical laboratory management. He is recipient of prestigious awards in various presentations. And of course, so we'll have him, Dr. Suri, speak on automated vessel morphology, optical RBC counting.
Thank you, sir, for your kind words. At the outset, I'd like to thank Dr. Anil Handu and the Mindray team for inviting me here. My talk is on hemocytomorphometry, a case-based approach. So I'll be taking up from where Dr. Anil left, as he rightly said that the modern analyzer is throwing a lot of histograms, scattergrams, and even a lot of flagging that we need to be aware of. And I would go a step further that not only we must train all our technologists on the bench to be aware of them, because unless those guys are aware, sometimes those slides may not reach our table also. So we have to first train ourselves and then we have to train our technologists also. So we'll try to look at some cases primarily from the histogram and scattergram point of view and try to see if we can make diagnosis even without seeing the slide or seeing the slide at the last moment. The diagnosis should be clear to us from the histogram and scattergram as much as possible. So this is the scatter plot that Dr. Handu had also shown in his presentation. I'll not talk about it in much detail, although there are three cell lines that I'll particularly want to talk about. One is the HFC or the green dots above the monocytes. These are the high fluorescent cells, or what you want to call them as the Downey cells, Turk cells, or transformed lymphocytes, virocytes, whatever you want to call them. They're usually increased in viral infections, particularly dengue, and also sometimes in certain lymphoid blasts as well. The next is the immature granulocytes, which are basically nothing but your promyelocyte, myelocyte and metamyelocyte put together. So now they have put a numerical count on it. We can develop our own biological reference interval for both HFC and IMG. And IMG is a useful marker in both diagnosis of bacteremia as well as septicemia. And this third cell line here that is this infected RBC. This is a scatter plot which is between the neutrophil and eosinophil on the scatter axis. And this is usually a diagnosis for the malarial parasite. So this is a very useful flag, infected RBC. So these are three new flags that I just wanted to bring to the notice of people who are not Mindray users. So this is my case study one. This is just a case that came to us about 15 days ago. This is a 36-year-old female, history of fever, ecchymosis and petechiae. So this is the platelet histogram. I think it is very clear to all. This is a case of thrombocytopenia. You can very clearly see from the histogram itself. This is the optical platelet scatter plot. On the y-axis is the forward scatter or the cell size, and on the x-axis is the fluorescence. So this blue and green area together is the area of the optical platelet, and the green portion is the area of the immature platelet fraction or reticulated platelet, whatever you want to call it. Clearly the IPF is very high in this case, so obviously there is some peripheral platelet destruction going on in this case. So these are the indices. As expected, the platelet count is 23,000, the IPF is 33, and this is monsoon season. So the most common diagnosis that we would entertain would be a dengue. But surprisingly, the clinician was also very confident about it being dengue. The NS1 was negative, the IgM was negative, the IgG antibody was negative, and the RT-PCR was also negative. And the clinician was very sure it is dengue. It was being managed with dengue, and it had already come through 3 labs to us. So previous labs, one had given dengue NS1 equivocal on the ELISA. So hence the dengue diagnosis was continuing. So this is the WBC scatter plot that I showed earlier. So this blue area here is the area of the neutrophil, but there is another area juxtaposing here. So when we rotate the cube, these two blue areas get discerned out. So this blue area between the neutrophil and the eosinophil is actually the area of the infected RBC or the malarial parasite. The machine also throws out a flag here. If you can see at the top right, it has given a flag of the infected RBC. So once that flag was there, I was very sure that this is now malaria, and I started to search for it. And believe me, even on the rapid card, it showed a very faint line. It had very low parasite density. And I had to search for more than 5 minutes to find the ring form. But this flag is very sensitive. It has got a sensitivity of 99.3%. and a specificity of 99.7%. So once you start looking for this flag, you will end up identifying a lot more malarial parasite than you would otherwise do. So the diagnosis was very clear before I even looked at this slide. It was Plasmodium vivax malaria with thrombocytopenia. This is next case. This is a 32-year-old vegetarian female. At a routine checkup with her physician, she complained of fatigue over the past 2 months. So as you can look at the RBC histogram, it is very clear. It is showing dimorphic, predominantly macrocytic anemia. The platelet histogram is showing some giant platelets because it is not touching the baseline at the upper discriminator. And if you look at the this blue area here, this is the area of the optical RBCs. And this pink area here is the area of the reticulocyte. From left to right, it becomes more immature. So clearly, as the reticulocyte is going all the way till the right, the IRF or the immature reticulocyte fraction is definitely higher. This is the optical RBC scatter plot. On the y-axis is the volume or the MCV, and on the x-axis is the hemoglobin concentration. So the area below is the area of the microcytosis and above is the macrocytosis. Left is hypochromia, right is hyperchromia. This center square is the normocytic normochromic. So as you can see, most of the scatter is in the area of the macrocytosis. So just from the visual impression, we know that this is macrocytic anemia. Now I'll show you the indices. So this is based on my theory of light scatter. When we have isovolumetrically sphered RBC as is there in a fluorescent analyzer, the low angle scatter shows the volume and the high angle scatter shows the hemoglobin concentration. So these are the indices. Hemoglobin is 9.7, MCV is 116, RDW is 20.8 and IRF is 22.3. So reticulocyte is normal but the IRF is high. This is typically what is there in an untreated megaloblastic anemia. But the strange part is that the folate, serum folate, RBC folate and B12 were all normal. So what could it be? Okay, I'll show you one more finding. We did an active B12 or the holo TC for this patient, it was low. So 50% of patients with B12 between 150 and 300 can actually turn out to be B12 deficient, because what we are measuring as B12 is the total B12, but most of it is in the bound form. Whereas what is important is the active or the free B12 or the holotranscobalamin, which is nothing but your active B12. So whenever a patient is between 150 and 300 and you are still suspecting megaloblastic, you should try and do an active B12 before envisaging or a more invasive procedure like a bone marrow. So yes, this was a case of megaloblastic anemia due to B12 deficiency. But the important point is that we are trying to diagnose it even before seeing the slide, even before trying to look at the indices, just from the histogram and the scatter plot. So this is the next case, 8-month-old child, fever, progressive lethargy and dark red urine for 24 hours. So this is the RBC histogram, otherwise pretty much okay, but a broad base, probably a high red cell distribution width. This is the rect scatter plot. As you can see that there is a lot of reticulocytosis and there is movement all the way to the right, so probably high IRF also. Now this is an interesting scatter plot. This is called the WNV scatter, where on the y-axis is the forward scatter or the cell size and on the x-axis is the fluorescence. So this blue area on the right, greenish blue, is the neutrophil. And here just between this pink and blue area, sometimes there is a yellow area which is called the basophil. And just on the left, this pink area is the area of the nucleated RBCs. So you can differentiate nucleated RBC, basophil and neutrophil in this scatter plot, which you cannot so much do on the bigger scatter plot. So clearly there are a lot of nucleated RBCs in this case. Just for your reference, this is how a WNV scatter plot would look. On the right will be the neutrophils, in the middle the yellow area will be the basophils, and to the left the pink area is the area of the nucleated RBCs. So we know there is reticulocytes, we know there is nucleated RBCs. Now these are the findings. Hemoglobin was 4.5, MCV 89, RDW 23.8, marked anisocytosis. TLC was elevated, reticulocytosis was there, and look at the nucleated RBC, 18 per 100 WBC. So we worked up for the hemolytic anemia. There was unconjugated bilirubin, haptoglobin was less. There was blood in the urine chemistry and the G6PD was pretty low. So this was basically a case of G6PD deficiency. Case 4, this is a 6-year-old female, history of viral fever 2 weeks ago. So this is the platelet histogram. Very clear that this is a case of thrombocytopenia. This is the optical platelet scattergram. Clearly the green area is very high, so there is very high immature platelet fraction. Obviously there is peripheral platelet destruction. These are the indices. Platelet count was 9,000, IPF was 39.3. The machine could not calculate the mean platelet volume, obviously a lot of giant platelets. But the dengue antigen and the antibodies were both negative. The doctor considered an ITP, treated with corticosteroid, and after corticosteroid the platelet increased to 97,000, IPF 4.8, IPF went down from 35 to 4.8. And this is the scatter plot of the later case. The platelet histogram is normal, and even if you look the area of the IPF, the green area has also reduced significantly. So this is the case of ITP. Fifth case, this is a dengue known case, NS1 positive case. I am just trying to follow the same patient from day 3 to day 8 to show how high fluorescent cells and immature platelet fractions can be used as a prognostic marker. So this is this case day 3, the platelet count is 171, HFC is 0.2. So the normal range at our lab for high fluorescent cell is 0 to 0.4. This is pretty much normal. This is the scatter plot, the platelet histogram is normal, and these small green dots here on top of the monocyte, these 3-4 green dots, these are the area of the HFC or the high fluorescent cells. Next day, platelet count went down to 82,000, HFC jumped to 3.7%. So HFC has become high. Usually on day 4, the HFC increases in a dengue case. If you look at the scatter plot, those green dots have increased, that area of the HFC above the monocyte, and the platelet histogram is still pretty much okay. Day 5, platelet count went down to 38,000, HFC jumped to 12.6. So you can see that the platelet histogram is now showing some spiking. It is not as good as it was in the earlier 2 days. And of course, the HFC scatter plot is more dense than the previous 2 days. Day 6, platelet count 43,000, HFC is 13.1. The platelet histogram is all over the place, and HFC is still having prominent intensity. Day 7, it could not discern the HFC because sometimes HFC get merged with the monocyte, the machine is not able to differentiate. But the platelet count is kind of plateaued at 57,000. Again, this is a gray scatter plot. The machine is not able to differentiate monocyte from HFC, and the platelet scatter plot histogram is still not quite okay. This is day 8. The platelet count has significantly increased to 99,000 and HFC has gone down. So as the platelet count increases, the HFC comes down. You can see on the scatter plot, the HFC scatter plot has reduced in intensity and the platelet histogram is near normal now. So 2-3 things that I want to show this case for. IPF or the immature platelet fraction begins to rise as there is peripheral platelet destruction in dengue patients. The HFC increases from day 4 of the onset of fever in all dengue patients. The platelet recovery usually begins within 48 to 72 hours of the peak IPF values, and there is a HFC intraday jump of 3 to 4 times after the onset of fever. And this is our own algorithm in monsoon season. It's not gone wrong because a febrile patient in monsoon season with platelet count less than 50,000, IPF more than 20% and HFC greater than 5%, all 3 conditions running concurrently, is almost certainly dengue irrespective of the serological status. Now this serological status can also be very tricky. NS1 is usually positive for the first 5 days and sometimes antibodies take day 7, day 8 to come. So the day between day 5 and day 7 is always a very tricky day where antigen could also be negative and antibody may also not have come. So these kind of algorithms are very useful in such scenarios. 6th case, this is an asymptomatic male patient who came for us for his annual checkup. So this is the WBC scatter plot. You can see that most machine could not discern the cell line, but there is a very intense scatter on the left of the eosinophil, mostly in the myeloid region. But the next scatter plot will give it away. That yellow region in that WNB scatter plot is the area of the basophil. So we know that there is basophilia, there is myeloid cell lineage. You are almost thinking CML right now. These are the indices. The counts are 2,33,000. There is thrombocytosis. There is 3% basophilia. The immature granulocyte, which is myelo, metamyelo, promyelo together are 51%. Our normal range is 0.6. And we diagnosed it as CML in chronic phase. The BCR ABL was also positive. This Dr. Handu has already discussed, so I will not discuss again. IMG. So this is the case of CML in chronic phase. BCR ABL was positive. The reason why I showed is that even before you look at this slide, just by looking at the histograms and scattergrams, you already know the diagnosis. This is case 7th. This is a 77-year-old lady who had come to us with history of weakness, vomiting, altered bowel habits, and pain and gum swelling for the past 15 days. So this is the differential scatter plot. As you can see, the maximum intensity is in this monocyte region, which is the pink region, followed by a lot of intensity in this blue region above the neutrophil, which is the area of the immature granulocyte. So definitely there is monocytosis in this case. This is the WNB scatter plot. There is no basophil, so we know that there is CML is pretty much ruled out.
So we have just 2 minutes for the talk.
This is my last slide. Yeah. So the platelet histogram showed thrombocytopenia. And there is a blast flag on the right hand side. This is my indices. Hemoglobin is 8.5, MCV is 107, WBC is 12,000, platelet count 28,000. Monocytosis was 32% and 12% were blasts. So we reported it out as AML with myeloid differentiation, and on flow and NGS it came out to be as AML M5. So as we've seen that most of these diagnoses we are able to make even before viewing this slide. Just by looking carefully at the histograms and scattergrams, we are able to conclude a lot of diagnoses and sometimes pick those that the clinician not even asked for, like in that malarial parasite thing. The clinicians are very sure it is dengue. So my takeaway message would be again that train yourself to look at a lot of data that is coming out of these machines, just as Dr. Anil said. But more importantly, train your technical staff as well, because the more trained they become on the histograms and scattergrams, the better smear reviews you are going to get and more better diagnosis that we all will be able to make. Thank you for your patience, and if there are any questions, I'll be glad to answer.
Thank you, Dr. Sunil, for beautifully illustrating your message through case studies, and I think it's extremely convincing in terms of how these abnormal populations or normal populations, when they become abnormal, throw light on the probable cause of those changes. I just had one query before I throw this talk open for discussion. In the case of ITP, was the patient put on treatment? If so, was it without doing a bone marrow? Was it based on only the CBC results?
Yeah, so it was done without putting the patient on bone marrow, sir. And the reason is being that the IPF was very high. In a case of hypoplasia, the IPF is less than even normal range. But here the IPF was 30-40%. It almost gives away the diagnosis of peripheral platelet destruction.
Fine. That's good. So any more question? Anybody? Yes.
As Sir said, the MCV and megaloblastic anemia does not correlate. I've seen cases like MCV is normal, 82, 87, but vitamin B12 level is low. So how do we explain that? Even the hypersegmented neutrophils also will not be there.
Could you be louder, ma'am? I couldn't get the question.
I think, let me explain. I think you are asking that you can get megaloblastic anemia without the MCV being high. And even the early sign of megaloblastosis in terms of hypersegmented neutrophils is not visible. Is that what you are saying? So
she's saying that megaloblastic anemia without MCV.
High MCV.
So there can be two things. In a diamorphic anemia also sometimes the MCV can be normal because there is simultaneously microcytic anemia. Otherwise also the neurological symptoms of B12 deficiency come at a much higher level. Usually at a level around 300 you can start manifesting the neurological symptoms. Whereas to manifest the hematological symptoms, usually you need to get down to levels of 100, 150. So I don't know whether you're talking about hematological manifestation or the neurological manifestation.
Hematological.
So most likely then it is a case of dimorphic anemia because
Yeah.
MCV could be normal there.
That's right. That's what is the answer. If you have a normal MCV, and but then you need to look at the RDW and simply look at the red cell histogram. So that will tell you whether the patient has a dimorphic anemia, wherein the patient will have low vitamin B12 and or folic acid and iron as well. So depending on that, I think you can make a diagnosis. So it's not uncommon to see dimorphic anemia which have normal MCV, yet the hemoglobin is low, and people don't pay attention to the RDW, and then you miss them. And also, a lot of us don't look at the red cell histogram. So you don't have to get into very high-tech analyzers for that. Very simple analyzers. If it gives you a good red cell histogram, you will be able to make out the diagnosis of dimorphic anemia from the red cell histogram and looking at the RDW.
Classically, the RBC histogram will usually have a bimodal peak.
Any more questions?
I have a question. Yeah, about megaloblastic anemia too. Have you seen that in these cases that are borderline between 150 and 200, that the methylmalonic acid or the homocysteine can be helpful or not?
I didn't get it, sir. Could you?
If you have seen in these cases that are borderline between 150 of B12 and 200, if the methylmalonic acid or the homocysteine are useful in these cases.
So methylmalonic acid is also can be used, but it is a very difficult test to produce in an automated laboratory environment. HoloTC is available on a lot of automated platforms and on the CLIA platform. So HoloTC is more reproducible from a laboratory point of view. But MMA can also be used. Methylmalonic acid can be used.
Doctors. Homocysteine.
Sir, similar to this.
So hyperhomocystinemia is usually seen more with folate than with B12 deficiency.
So on the other hand, we have a high MCV, but vitamin B12 and folic acid are normal, and picture is in bone marrow biopsy and aspirate is megaloblastic. So you told about active vitamin B12.
Yes, ma'am.
What is about that? Little details.
So active B12 is nothing but your holotranscobalamin. It is the active or the free form of the B12.
How
So-
to test that?
So that can be tested by using HoloTC or active B12 on certain analyzer. If I am permitted to take names, so maybe you can do on Abbott or Roche platform.
So, Dr. Suri, there are two questions which are online, so I'm just reading them out. One is, are there studies regarding reference values for the hematology parameters which you spoke about in your talk? So, this is the first one.
So
Yeah.
you want to take the second also, sir?
No, I think you finish on the first one.
Yeah. So each lab must develop their own biological reference interval. Don't copy my biological reference interval and start using in your lab, because most of these parameters are based on fluorescence. And the fluorescence dye between different manufacturers is also different. Even within the same manufacturer, different instruments have got a different algorithm. And last but not the least, sometimes some of these parameters are dependent on ethnicity. So what is applicable to my part of the city may not be applicable to your part of the country. So develop your own biological reference interval and then only begin reporting these parameters.
So, the other question which is there, which you had actually kind of touched upon during your presentation, but I'm just reading it out because, again, online there is a need for this to be answered. And it says, is there any correlation with presence of large lymphoid cells or the high fluorescent cells in the analyzer with dengue serology or NS1 testing?
Yeah. So high fluorescent cells or downy cells, whatever you want to call them, are present in a lot of viral infections and even some lymphoid malignancies as well. But in a post-monsoon season or just this time about August to September, October, if you see HFC more than 5% in a viral infection scenario, it is usually not other viral infections. It is almost certain to be dengue.
Thank you. I think that answers the question.
If there are no more questions, we'll be closing. But before that, just a point to answer your question. If you have a macrocytic anemia, which is not supported by a lab evidence of B12 folic acid deficiency, anyway, you have to think of myelodysplastic syndrome. Because at the end of the day, after therapy and all that stuff, a lot of cases, they turn out to be that. So it's just from general knowledge that I'm sharing with you for the benefit of the rest of the audience. I think we'll stop here with Shamma's permission.
Moving further today, we call the third speaker of the day Dr. Arpan Mehta, and I request Dr. Ramon to introduce Dr. Arpan to our esteemed audience. Despite of a busy schedule, Dr. Arpan has made up some time for today, and we are grateful for this gesture of his. Actually, we have preponed his topic today since he has some important work to do tomorrow. And may I request Dr. Ramon, what should I say about Dr. Ramon? But just to mention a few, Dr. Ramon is an expert in clinical and laboratory hematology, oncology, immunology, immunotherapy, coagulation, blood banking, flow cytometry, blood cell morphology, clinical hematology, anemia, laboratory information system, it's a tongue twister, medical statistics, expert systems, and artificial intelligence. So may I request Dr. Ramon to introduce our next speaker, Dr. Arpan Mehta, to us?
Yes, it will be my pleasure to introduce Dr. Arpan Mehta. He is a laboratory, he has pursued postdoctoral fellowships in laboratory hematology in Tata Medical Center, also in laboratory hematology in CMC Vellore, in molecular hematology oncology in Tata Memorial Hospital, and he is the responsible for pathology from Medical College Baroda. Currently, he's working with Newberg Diagnosis, Ahmedabad, from the past 5 years. His areas of expertise are flow cytometry and next-generation sequencing in myeloid malignancies. Really exactly what we need now. Thank you. The floor is yours.
I hope I am audible. Yes. So, very good afternoon to all of you. Thanks a lot for your kind words of introduction. So, I shall be focusing on the cystocyte quantification. So, here is how I shall go about it. So, we shall be discussing on what are they, how do they look, when to count them, in which conditions do we call them significant, and then followed by a few words on automation and digital morphology. So basically, its name is derived from Greek word cysto, that means broken or cleft. And they are circulating fragments of red blood cells or RBCs from which cytoplasmic fragments have been lost. And they are formed by mechanical damage to the membrane, which is caused by fibrin strands on the endothelial surface and by turbulence of blood. So this is a short animation which shows a red blood cell traversing through the blood vessel and fibrin strand tearing it apart. So this is the same thing at a different plane. So basically, back then, way back, there was a lot of confusion or rather lack of consensus as to which cells we count as cystocytes. So ICSH in 2012 came up with recommendations on how to identify them, in which conditions do we call them, and how to quantify them. And this is the recent, couple of years back, 2021 update on the same. So basically, cystocytes are always smaller than the intact red blood cells and should be counted in 4 different types. So first type being the small fragments of varying shape, sometimes with sharp angles or spines, in which case we call them as triangle cystocytes, with straight borders, so sometimes with a round outline on one side, in which case we call them as microcrescents, often distorted, staining darkly or occasionally pale. So this is a microcrescent. The second type being helmet cells. We all know them. So these are helmet cells. Third type being the damaged cells, which are larger than smaller fragments, and they have a pair of spicules. They are separated by semicircular concave segment, sometimes even 2 or 3 pairs, and they are usually named as keratocytes. So these are how keratocytes appear. And this is the last variety. These are small sized hyperdense red blood cells with a round shape and increased staining, just like they seem as spherocytes. And most important thing is that they should be counted as cystocytes only in the presence of other types of cystocytes. So this is how they look. So this is a keratocyte, this is a helmet cell, this is a triangle cystocyte, these are microspherocytes, this is the helmet cell, this is a microspherocyte, this is a keratocyte, and these are microcrescents. So these are the type or scenarios where we don't call them as cystocytes. So these are spherocytes. In absence of other types of cystocytes, we don't call them. So these are irregularly contracted cells. These are acanthocytes. And these are sickle cells. In these scenarios, we don't call them as cystocytes. Please note that these sickle cells are larger than the surrounding red blood cells. So these are cystocytes, but these are not cystocytes. Again, these are triangle cystocytes. Likewise, these are not cystocytes, but this is a cystocyte. So like that. So the latest update of 2021 update states that standard procedures for smearing and staining blood films are essential. This is very important, as if we don't follow them, then we will see artifactual cystocytes. And the standardized count should be done, it is stable rather, up to 3 hours from the blood collection if it is at room temperature, and 8 hours if it is stored at 4 degrees. So how to count them? So first of all, we need to select an area where RBCs are just overlapping, and then we go into high power or oil immersion lens. We should not select the area which is at feathered edge where we see all spherocytes. And then we start counting the red blood cells and cystocytes, put them in the formula, and the recommendation is to count 1000 red blood cells. Now coming to Rumke distribution table, which shows confidence limits of an observed percentage of cystocytes depending upon the red blood cells counted. So as you can see here, if you consider true value of cystocytes as 1%, and if you count 100 red blood cells, there is a very wide range, 0 to 5.4. If you want to improve this precision, then we need to count more and more red blood cells. So 1000 is a good thing to do, and 10,000 is the best thing to do. So the recommendation is to count at least 1000 red blood cells, and preferably 10,000. Now whether it is possible to count 10,000? Well, the answer is no, because an average time to count 1000 is estimated to be about 10 minutes. So if the real world application rather of 10,000 cell count is prohibitive in terms of balancing resource requirements to potentially exhaustive resourcing required to achieve better agreement. So 1000 is a reasonable cutoff, or rather the best balance between time and resources. But if we still want to count 10,000 red blood cells, there is an intermediate method that we can use. Of course, this is not a recommendation. What we can do is we can select an area where RBCs are just overlapping and homogeneously spread. We go into oil, and then this average field usually has about 200 red blood cells rather. We can count 50 such fields and obtain or reach 10,000 red blood cells. So suppose this is a field, then we can have an imaginary plane and then start counting the number of red blood cells. After counting the red blood cells, we can start counting cystocytes like this, and then go on for other 50 fields. So then we can reach to 10,000. We can put that in this formula and we can get the percentage of cystocytes. So the clinical utility of cystocyte quantitation lies in distinguishing whether it is there or it is not there. Rather, it is less than 1% or it is more than 1%. So ultimately, the cutoff of 1% matters a lot. And this is the distribution of the type of cystocytes. As you can see, helmet cells and crescents, they are the predominant forms, while the triangular cells, keratocytes and microspherocytes are the less predominant forms. And it is not that you will see only cystocytes in only TTP and HUS, but you can see in all other conditions like hematological malignancies or megaloblastic anemias or metastatic carcinomas or sepsis or renal failures to infection to others also. So the presence of cystocytes, even if associated with severe thrombocytopenia, may not specifically identify cases of thrombotic microangiopathy. And the converse is also true, that lack of cystocytosis also does not exclude a diagnosis of TMA. So this is a very good example. This is a case of megaloblastic anemia. So you can see cystocytes here also, but surrounding you can see macrovalocytes, Howell-Jolly bodies, hypersegmented neutrophils. So you can be sure that this is not the predominant abnormality. So cystocytes here are not the predominant abnormality. So these are the upper limits of normal individuals. So in healthy adult, it is about 0.2%. In neonate, it is 1.9%. And in premature neonates, it is about 5.5%. So cutoff, or rather the presence of cystocytes is significant only in two settings. One is thrombotic microangiopathy, that is TTP or HUS, in which case the cutoff is 1%. And second is transplant associated thrombotic microangiopathy, in which case the cutoff is 4%. In all other conditions, where cystocyte is not the predominant abnormality, we need to qualitatively grade it and mention in final report that it is not the predominant abnormality. And the recent update, that is 2021 update, states that 1% cutoff is there for adults and full-term neonates, and for premature babies it is 5%. So if you want to qualitatively grade it, it is less than 1%, 1 to 2%, and more than 2%, like that. So this is a bland and alternate plot which shows the correlation between different observers. So if you see at lower cystocyte percentages, there is good agreement. As you move higher, there is higher cystocyte count, there is less agreement among the observers. And this is the latest algorithm that is given on how to approach cases of cystocytes. So whenever there is a suspicion of TMA or there is an automated FRC count which is positive, then we need to check whether cystocytes are there on smear or not, or by a digital scan. If they are there, we check whether it is the predominant abnormality or not. If it is not the predominant abnormality, still we are suspecting, if we have still strong clinical suspicion of TMA, we examine the film daily. In other case, we think of an alternate diagnosis. If cystocyte is the predominant abnormality, then we start counting them and report as we discussed earlier. Coming to automation, that is fragmented red blood cells. So they have a lot of advantage. There is good reproducibility. It counts lot of cells. It is available within minutes, does not require an expert to report, and it has good sensitivity and negative predictive value. So this is important. It has good sensitivity and good negative predictive value. But it has limitations that often overestimates or underestimates the count, and it is quite well known. It's affected by hypochromia, it is low specificity, and it is not recommended to be used in isolation. So there are different analyzers which analyze FRC differently. This is one type in which the platelets are counted if the volume is less than 30 femtoliters and refractive index between 1.35 to 1.4, and RBC fragments or FRC corresponds to those with having refractive index more than 1.4. So if flag is triggered when it crosses a certain value. This is the second type of analyzer in which x-axis shows fluorescence and y-axis shows forward scatter. So first a gate is drawn, gate T, so that demarcates RBCs from platelets, and after drawing that, another gate is drawn, that is gate 1. So that shows the number of cystocytes corresponding to number of RBCs. And if there are lot of small red blood cells, also it offers a correction factor through another gate, that is microerythrocyte distribution area. So there are a lot of published papers on the range of FRCs, predominantly by one or two analyzers only. So a common cutoff we can use is 0.5%. So as I said before, there are a lot of false positives in FRC, but it has a very good sensitivity and very good negative predictive value, meaning thereby that if you get an FRC as normal, then you are quite reasonably sure that there are no cystocytes in the smear. So this was one of our cases. It was suspected case of HUS, and with treatment the cystocyte percentage decreased, and it quite well correlated with the cystocyte percentage with FRC and FRC absolute. So evidence-based statements are put forward which states that FRC results and flags are helpful screening test. The absence is a valuable parameter to exclude cystocytes on blood film. Many studies are still required to draw a reference range, and samples with positive FRC should be checked by optical microscopy. So once we get a positive FRC, we need to check by optical microscopy. Coming to digital morphology for cystocytes. So now we are already into AI era. So we have also installed MC80 in our lab, and it is really nice that it automatically scans, it differentiates into different RBC types, and it also quantifies them. So I just pulled out few cases just to show. So this was a suspected case of TTP. So in that MC80 showed 7.6%, and manually we got about 4.7%. So it slightly overestimates. As you can see, the round things that I've shown, they are not cystocytes, but still they are counted. This was another case suspected for HUS. we got 2.7% and MCAT showed 3.3%. So it was kind of quite concordant. This was another case. This was concordant. It was 1.6 on the machine and 1.45 on optical microscopy. This was again 16.9 on MCAT and 12.9 on optical microscopy. So this actually overestimated. And this was 1.58 versus 3.7%. So we just plotted a bland and alternate plot, and if you can see, the MCAT actually slightly overestimates, but at lower percentages, there is quite a good concordance, but at higher percentages, it is not true. But it also flags cases of not TMAs, like we see here a G6PD deficiency. It had a lot of byte cells, but it counted them as cystocytes. This was a routine checkup in which it got a value of 0.5%. This was suspected to have a megaloblastic anemia, and it shows 0.8%. This was suspected dengue, but it counted a false area, which showed gross overestimation of cystocytes. So this was a study that was performed on CellaVision, which showed a very high sensitivity, but rather poor specificity, like we showed. And it also slightly showed higher values for cystocyte as compared to as compared to manual analysis. It showed higher values in automated analysis. So the bottom line is that it requires manual revision. Even in this paper, 2/3 of the cystocyte which was counted by the machine, they were not actually cystocytes. And the final count of cystocytes in that, about 1/4 of them were classified as other type of red blood cells, which were actually cystocytes. So I want to conclude saying that cystocyte count has a definite clinical value in thrombotic microangiopathy in absence of additional severe red cell shape abnormalities with a confident threshold value of 1%. So 1% is the cutoff. Automated counting of fragments is also recommended by ICSH group, but as a complement to the microscope, according to high predictive value of negative results. And finally, cystocyte pre-classification provided by digital morphology analyzers requires confirmation with the optical microscope. Thank you so much.
Two things I want to say: that a fragmented cell is counted in the machine as a schistocyte, but a schistocyte has to be fully hemoglobinized. A fragmented cell may be hypochromic, it may be fragmented, but it will not be fully hemoglobinized. And that's why we see the discrepancy between the AI of the machines, which are only counting fragments.
Yes.
But a true schistocyte is a fully hemoglobinized cell. And that's why so far, I think we need to see the slides before we can call. Of course, the hemoglobin, how will you measure in these fragments?
Yes, so there are 2 points to your comments, ma'am. So basically, what you're saying is correct, that we need to check by optical microscopy, and that is what the recommendation is. Whatever the machine gives, either it is FRC or either it is the digital scan, we need to confirm with the help of microscopy. Regarding hemoglobinization, our understanding at 2012 recommendations was the same as you are saying, but recently they have modified in 2021 as they also incorporate those cells which are falling into the criteria of all 4 types, but we are still having slight central area of pallor or loss of hemoglobin. They are still counting it, but there is a recent recommendation only in 2021.
Very good talk. I had a question. Like while you are saying that there are limitations and there may be so much of morphological variants of these fragmented cells, what is your protocol of commenting on schistocyte index in premature babies? Because many a times these pycnocytes come into the peripheral blood and people get confused whether to really count them as fragmentation or just mention them. So what is your take on the presence of pycnocytes?
First of all, thank you so much for your comment. Second thing is regarding the premature babies, the recent recommendation 2021 update states a cutoff of 5.5%. Like you said, there are pycnocytes that we see. I don't exactly remember. The Barbara Bain blood cells book mentions even a range for pycnocytes that it is agreeable to accept. So they also say that around 5% we can see cystocytes, which might include if it is falling in all four types. But still, we will keep a cutoff of 5.5% and not 1%.
You run FRC on these cases? Or it's just the morphological percentage you rely on?
So the thing is that I usually report NGS and stuff. The routine is not reported by me, but in our lab, whenever there is an index of suspicion, both ways, either it is from the clinician side or either it is from the pathologist side, they send me for an opinion, in which case I see. So they of course look at the routine thing. So I'll just share a small experience that before MCAT it was different and after MCAT is different. Before MCAT, we used to see all the smears, this and that. But after MCAT, we now have started relying on the automated parameters and digital scan. So we can just in a snap have a look at it. Of course, it is not gold standard and we will have a lot of false positives. But kind of once we start using that instrument, we will start getting comfort zone and we will try and identify, or we will identify those cases which it is missing. So we will know where we need to be cautious and where we need not to be cautious.
Thank you.
We have another question from Dr. Rakshika.
This is regarding the schistocyte automated FRC count. Is there any false positive value that you have seen with cases of extravascular hemolysis apart from intravascular hemolysis? For example, in extreme anisopoikilocytosis associated with sickle thal or thalassemia, beta thalassemia major.
Yes, so definitely FRC count, it will means count that area in which RBCs will fall into that graph that I showed you. So in the cases that you are describing like sickle cell, you will have some microcytosis here and there. So RBCs will fall in that area. Even though the microerythrocyte distribution area will correct that thing, but it will not be able to correct so much. So definitely it will have false positive, and that is also reflected in the recommendation, in which case they state that FRC count is a sensitive indicator, but it is not a specific indicator.
Okay. I have a comment and a question from me. When Dr. Professor Gini was explaining and showing in the ISCSH his work, I asked her what can be useful for the people that are not expert in cell morphology to see if they are real schistocytes or not. She told me that the presence of some spherocytes, because the pathway of the schistocyte is become spherocyte and after to be lysed. But my question for you is, which parameters from chemistry or immunochemistry can be helpful for the same to suspect schistocytes, aptoglobin, indirect bilirubin, LDH? What is your experience about which parameters from the chemistry can help?
Yes, so the index of clinical suspicion comes from the clinicians. Basically, they look at, suppose they're thinking of renal failure, so a race create, along with signs of hemolysis that you are seeing NRBCs, the hemoglobin is dropping, the reticulocytosis is there, all these things like LDH, indirect bilirubin, all these cases here and there, there will not be like one thing, short for one thing, but a combination of all these parameters would help raise a clinical suspicion. And of course, when we look at smear, suppose hemoglobin is 7, we are looking at smear, we'll pick up cystocytes, not a big deal. But for those which are not experienced, like you are saying, for them, FRC count will be really helpful because they will flag that thing to be reviewed by an expert like that.
Thank you very much.
Now I would request one legend to introduce another legend. So I request Dr. Amardas Gupta to be a chairperson to chair the session of Dr. Ramon.
It's a privilege. Thanks, Shama. To introduce Dr. Ramon Simon. I didn't know he has a Lopez also at the end. I know him more as Ramon Simon. Our contact goes back maybe a decade or maybe even more than that. And I am tremendously impressed by his insights into cell morphology, cell counting, and all the allied areas of basic hematology. Although we heard that he has a very wide range of interests and he has definitely worked very intensively in these areas as well. But and that is listed here. So I don't think any field of hematology is left behind, but I always associate him with the with the pioneering and the insightful work that he has done in the field of cell counting, cell morphology, changes in diseases and the understanding thereof. So without wasting much time, it's a privilege, Ramon, to introduce you to the audience here, and welcome to India again.
Thank you so much.
Look forward to hearing.
Thank you so much. Okay, let's talk about cell population data, the need to have automated leukocyte morphology. Lately, in company Mindray has been several developments that has been introducing new concepts in hematology. One of them was the SF cube. The SF cube is the first multidimensional analysis of the cells using not only the forward scatter, the side scatter, also the fluorescence that measures the size, basically measures the size of the nucleus. That is very important because, as you know, one of the criteria for malignant cells is the relationship between the cell size and the nuclear size. For this reason, being practical, when I explain cell fluorescence is the size of the nucleus. Also, in addition to that, lately has been developed the multi-layer fusion technology for imaging, the MC80. And I will mention after several aspects that makes this technology unique. But also the more important thing is the same company have both technologies in the same automation line. Last but not least is the introduction of artificial intelligence. Artificial intelligence not to replace us, but to help us. To help us having a better detection of malignant cells, of blast. As we will see, the results are amazing. You can see here in this center slide is doing a multi-layer focusing with immersion oil. That is the only technology that uses immersion oil in 100 plus objective to do a perfect visualization of the cells, able to do diagnosis. Before that, many of the users were having to look for the smear to see if they are blast, in which type. Yeah, you can do it for screening, but for the diagnosis, they were going to the microscope. Here is not anymore necessary because you have a 100 plus immersion oil objective. The best of in this moment for Mindray, because one of the things I like that now I collaborate as a scientific and medical affairs responsible for Mindray is the continuous improvement. In the last months, we have seen the presence of the concentrated reagent delivery system that avoids to bring for the medical technologies and the nurses the weighty containers of the sample processor. That is very important because, as we have seen, many of the parameters are affected by the temperature, and this sample processor will keep the samples at the good temperature to be able to reanalyze with very similar results after several hours. Of course, the instruments, the CBC, retic, platelet, optical platelets, and IPF, the BC6800 or BC6200, the new instrument that measures erythrocyte sedimentation rate, CRP and serum amyloid, both all of them inflammatory and infection markers that are very useful, and you can do all in one test, in one tube. The auto slide, the slide maker, the SC120, the digital cell morphology instrument that read the smears and is able to show us the high quality images, and last but not least, the hemoglobin A1C for diabetes diagnosis. Let's go for the one by one for these instruments. The BC6200 or BC6800 are able to do the SF cube and to give us the best flagging for malignant cells, as we will see in some of the studies that have done recently. The Mindray SC100 is automating the slide smear with a very unique sapphire slide that permits to keep the quality of the slides for a long time without any breaking of the instrument. And finally, you can see the quality of the cells, and it's the only one with 100 plus immersion oil objective. But we have, and now it comes my talk, we have MCV, RDW for red cells. We have MPV, PDW, and IPF for platelets. But why we don't have any cell morphology parameter for the leukocytes when they are so important? And that was the focus of my career from 1999, in that I published a poster in the ASH about how to use the cell population data for the improvement of the laboratory hematology diagnosis. And this is the important thing to know. These are lymphocytes, but how different they are. Will be important to know the size of the nucleus. Will be important to know the size of the cell, because these nucleus are very similar. The plasma cell leukemia and the CLL, but the cytoplasm is absolutely different. One is very small, and we can see that combining the cellular size and the nuclear size. And if we can use that and combine them, why don't we use it? Neutrophils, again. These cells are one hypogranular neutrophil, one normogranular neutrophil. Will be nice to know that there are some neutrophils that are hypogranular. And what happens when they are very big? The size of the neutrophils, and then if they are segmented. Neutrophil X is useful to detect hypogranular cells, and neutrophil X also, when it's very high, toxic granulation or hypersegmentation. The same for the monocytes. Don't forget the monocytes. I did one study that we will see afterwards, how the monocyte size can predict the cytokine storm in the COVID patients, but also in the dengue patients that become hemorrhagic fever. Also the Ebola or other hemorrhagic fevers, before to enter in this pathway of the hemorrhagic fever, of the severe and deadly situation, monocyte size goes high. Cell population data. Here we have these parameters that comes out of the normal CBC, and the first publication I did myself in 2000 in blood, and the first patent was about malaria in 2007. And these are the cell population data from Mindray. This was a study done to see the reference values of these parameters. I have to say that we are in the process to get calibration and control materials to everybody can have the same results in the world. For the moment, everybody has to calibrate and to know its own reference values. There is something very useful that I will say is export your database, select normals, numerically normals and non-flags, and getting the average of these cell PD, cell population data of these normals, you will be able to monitor if your reference values are stable in the time. This is now coming much more, the resolution of the projector is not so good, but you will maybe see. These are the neutrophil, the monocytes, and the lymphocyte cell population data, and this is ALL, AML, CLL, sepsis, viral infections. What I want you to see here is a potpourri of viral infections, sepsis, AML, mantle cell lymphoma, multiple myeloma. Look, the parameters, cell population data, when they are high, they are red. When they are very high, are bold red. When they are low, is blue. When they are very low, are bold blue. All the patterns for all the diseases are different. Combining them and using artificial intelligence or using rules, we can help to suspect hematological disorders. This study was done by Dr. Sabrina Boro in Italy. There are many posters now and many investigations running. I will only collect the ones presented in the ISLH 2022 in Bologna, in that were presented from Mindray 35 posters from customers about IPF, about sepsis, about cell population data, about blast detection, AML, dengue, etc. This is one of the images of the Congress. In this Congress were presented applications of cell population data for anemia. Leukocytes for anemia, yes. In this study was done by Stefania Landucci from Rome about how to detect myelodysplastic syndromes with the automated parameters, with the CBC. And he was demonstrating that the use of neutrophil scatter was very useful with a ROC curve of 0.5858, sensitivity of 95%, detecting dysplastic neutrophils, degranulated neutrophils, and detecting, suspecting myelodysplastic syndromes. This is amazing, and it's for free. It's included in the 6,800, and maybe one of these days, Shama will give the good news that other instruments will incorporate to cell population data. Another of the studies was done in anemia, was done by one of the doctors presented here, Dr. Hiren Danani, that we did this investigation together, in that he demonstrated that in megaloblastic anemia, not only the microcyte count, that was very good also, but the monocyte fluorescence, the monocyte size, and the neutrophil scatter were very good for detecting megaloblastic anemia. And this is very important because 50% of the megaloblastic anemias, if we do in a random series of 500, 1,000 anemias, random, we do B12, we will find that half of them have normal MCV. And the problem is the GPs don't order B12 if the MCV is normal. For this reason, this is really an issue. And using the free, no charge, cell population data, we can have a flag and suspect and order B12 deficiency when the MCV is normal, there is an anemia, but the neutrophil size, the monocyte size is high, neutrophil macrocytosis, monocyte macrocytosis, we can suspect megaloblastic anemia. The neutrophil X shows hypersegmentation that also helps in addition to suspect megaloblastic anemia. Applications of cell population data for sepsis. There were two studies, one that is now an article, the poster was presented also in Bologna, I will present the article, not the poster, in that they were saying that monocyte X and neutrophil monocyte scatter and neutrophil fluorescence having a ROC curve more than 0.7 were very useful to suspect sepsis. But look, they were checking also procalcitonin, and procalcitonin was lower efficiency, area under the curve, 0.65, lower than the cell population data. And cell population data is for free in the people that have the 6,800. Please don't forget the hematological parameters. Also was presented another poster about how to automate the detection of sepsis by Italy. In that, they were using the neutrophil X, the neutrophil scatter, that shows the hypergranularity, and the neutrophil complexity, the neutrophil fluorescence that is correlated with the size of the nucleus. Metamyelocytes have higher nucleus than segment. Myelocytes even higher, and promyelocytes even higher, with an area under the curve of 0.935. And the monocyte X, 0.855. This is amazing, and only with parameters that are incorporated in the instrument for free. Last but not least, this is not cell population data, but is using also the position of the cells. It was a very nice study comparing. It was a ROC curve showing better performance detecting cancer cells in body fluids of the Mindray 6800 compared with the 6MEC610. For this reason, we are using also the morphology of the cells in the plots, in the scatter plots, to measure and detect better cancer cells. This is a study I did myself in collaboration with Wuhan, as a hospital in the beginning of the COVID infection, analyzing 447 samples from 92 patients of COVID. In this case, for me, it was good also to assess if they have severe COVID or mild COVID. But the more important was to predict, because I am focused in the clinical application of the parameters. And I was interested in to predict which patients will go bad, which patients will go good. And I detected that the monocytes were higher, the group 5, before the cytokine storm. And that was very useful. And I will show you the group 5 is 1 day before the cytokine storm, 1 day before the patient became severe. What was happening? The monocyte size that was constantly normal, it increased and after became normal. As you can see here, the monocyte Z, the monocyte size was followed and become bigger and after lower. And that you can see the photos of the monocytes. For this reason, the monocyte size is a good predictive value of a cytokine storm in sepsis and in COVID. Similar approach can be used for dengue. Application of cell population data and artificial intelligence for the detection of malignant cells. The malignant detection can be in the instrument by the flags, and it was an article published also in Bologna that's applying a rule. Without the rule, the sensitivity was 97% for blast, the best from all the other companies if you see any study in the sensitivity of blast. But we were using the cell population data and the cells and the CBC parameters. If leukocytes more than 16,000, neutrophils more than 15,000, hematograms more than 27, and neutrophil fluorescence more than 470, suspect promyelocytes blast. And with that, the sensitivity became 100% with only 2 more false positive. For the reason, cell population data can be used to tailor our sensitivity for any disease. But after we have the malignant detection with MC80, and MC80 have also cell population data, and we can manage in Mindray this information to improve the whole automation line sensitivity for malignant cells. The CBC cell population data and the stained cells cell population data. And in this article, it was shown that the correlation of the MC80 blast with the pathologist was 0.985, but the cell vision have 0.883, higher than one of the leaders in the market of digital imaging. Why? Because it's using the 100 plus immersion oil, and the other node is not using immersion oil. The quality of the image is much better to get much better information about the cells. Here we can see the sensitivity for the different abnormal cells that was 93%, 95%, 94%. And this is the technology is using to do this job. We can see an example of blast cells, how they can be seen in the MC80. Dozens of new parameters for cell diagnosis that are, together with cell population data, improving. But now we have the color and the texture of the nucleus and the color and the granulation of the cytoplasm. And now we have this combination of information to improve the diagnosis. Also, we can have red cells, but this has been shown. I will not enter on that. An image of the red cells and the platelets. But the instrument is detecting, pre-classifying the schistocytes, the target cells, etc. One clinical case only, that I always use this clinical case because I'm reminding everybody the typical pattern for a population in the myeloid, monocytoid area with 19,000 leukocytes, with 89 platelets, 89,000, not a lot, not very low, and as you will see, abnormal promyelocytes. Look the quality of the cells in the MC80. Acute promyelocytic leukemia. By conclusion, the highest sensitivity for the detection of hematology malignancies thanks to the use of cell population data automatically, or we can create even more rules to even improve the detection. We can tailor the sensitivity we want in our lab. The highest throughput and highest sensitivity for the detection of hematology using digital imaging. For the moment, we cannot dispose these parameters, but Mindray is trying to get also the highest sensitivity in digital imaging. This is a lymphocyte from a teenage lady that was having her first relationship, and of course, she got, in this case, an Epstein-Barr virus, and this is an infectious mononucleosis really from digital imaging. Thank you very much.
Very interesting talk and nice presentation. And I love this last slide the most. Any question for Dr. Salman?
Very nice. Dr. Rebon, always a pleasure to listen to you. This talk has highlighted the importance of early submission of the sample to the machine, because the changes of morphology we know occur within 3 to 4 hours. And we have seen such weird looking mononuclear cells. And I think we must realize to get a good cell population data, we have to submit the sample to the machine as early as possible.
Yeah.
And I think the main important thing is maybe we say 6 hours, but I think nothing beyond 2 hours will be good for a good cell population data. I don't know what is your cutoff. Normally we say make a smear within an hour after collection of a sample in the EDTA.
Yesterday evening, I was going to the bed a little late because I was doing precisely this study from a doctor from Italy.
Yeah.
She is presenting, Dr. Rolla, an article on sepsis, and the peer review asked, what is the stability of these parameters? Right. And we were analyzing the stability of these parameters at room temperature and at 4 degrees. The thing is, at 4 degrees, you have to keep at 4 degrees when you have to analyze more than 6 hours.
6 hours.
Before is better at room temperature. But one condition, if you keep the samples cold, you have to analyze the samples cold. For this reason, this is an important point. If the cells are after 12 hours, after 18 hours, for any reason, the sample arrived from an external lab.
Yeah.
If you have to analyze it, keep attention, don't wait that the sample get room temperature. Analyze the sample cold.
Cold, yeah.
Yes, when this article from Dr. Rolla will be published, you will see the data of the stability of cell PD that is mandatory for every study, every publication you do. Thank you for your comment.
No, it's absolutely necessary because we are looking at the morphology of a cell.
Yeah.
Basically, machine is also looking at that. So.
Yeah, and the
Thank you
neutrophils
so
have a medium life of 6 hours.
Yes.
And after that, they change the morphology for sure.
Totally. Thank you.
You're
Thank
welcome.
you.
That people hate errors. I love errors.
Okay.
Because I love errors because I collect them and I analyze them and I check for the cell population data and I use them to continuous improvement. Every month, every 2 months, I like to collect all these errors and to try to find a way to avoid that they happen again, to get the Six Sigma. For the reason I love errors and I encourage the people to bring me the errors. Don't hide the error like nobody see me. No, love the errors because the errors will improve your laboratory practice in the time.
Thank you, sir. Good afternoon, everyone. So, first of all, I would like to say my thanks to the organizing team for this big event, Dr. Anil and the whole Mindray organizing team. Thanks for giving me this opportunity. So this is about role of hematology analyzer as a diagnostic decryptor in monocytosis. So I would like to show a few cases where we can see how frequently we get this flag of monocytosis when we run the samples in the lab on day-to-day basis. So this is about a 50-year-old female presenting with fever, chest pain, joint pain. The CT showed aortitis and pleural effusion. Patient was put on ATT thinking of it could be a tuberculosis. Patient also had oral ulcer, thrush, diarrhea since 1 month. And on investigations, she was found to have leukocytosis and monocytosis. On CBC analysis, there was anemia, mild thrombocytopenia, and a flag of monocytosis, which we can see here. I'll come to the details later that how it was like hematology analyzer can play an important role in this. But on morphology, there were around 73% blast with monocytic features. On flow cytometry, these showed monomarkers. The morphology and flow was consistent with AML with monocytic differentiation. So this was the morphology which we can see clearly. The second case, a 70-year-old male, again with recurrent fever for last 6 months, pallor, hypothyroidism, again TB with pleural effusion, with history of sepsis, lower respiratory tract infection, weight loss, and again it showed persistence of monocytosis along with leukocytosis. We found monocytosis in the differential. There was anemia and leukocytosis. So here also there was a flag of monocytosis, and on investigations, there were some monocytes which were showing atypical forms. Not every time they show a beautiful typical morphology, and we get easily confused that what it could be. So marrow was also done in this case where there were some cells showing blastic or query promonocytic morphology comprising 5%. So it was a possibility of MDS-MPN query CMML over reactive monocytosis since patient was already a diagnosed case of TB. So it was a possibility which on peripheral blood doing flow cytometry showed around 98.2% classical monocytes. I'll be discussing these monocytic fractions now after a few slides. So in the third case, again, similar kind of presentation showing monocytosis. And here also we can see that there was presence of these monocytes in the peripheral blood, and later on the patient was diagnosed as tuberculosis. Another case, in fact, father of a clinician who's a close colleague, he presented with history of gallstone, persistence of monocytosis, and there was a concern that what could be these cells. When the CBC was done, there was thrombocytopenia in addition to monocytes, and when we investigated it further, it came to be reactive proliferation of monocyte. So we can see that in all these cases, monocytosis was a very common finding which was present in CBC analysis, and there being so many neoplastic and benign etiologies of monocytosis, it becomes very important to decide like how to go about it. And hematology analyzers being the first step, once the sample arrives in a lab, it can play a very important role in detecting how to diagnose whether these monocytes are actually neoplastic or they are just a benign proliferation because of a secondary cause. So as per the WHO, we know there has to be a criteria for absolute count more than 1000 per microliter or monocytes being more than 10% of leukocytes presenting for showing persistence for more than 3 months. So this reactive monocytosis being a close differential of CMML, so it leads to a demand for the microscopic screening, and many a times it may not be really required and time consuming. A skilled personnel is required, and of course there is a cost involvement. And it is a serious concern in high volume laboratories like how much time one has to spend on the peripheral blood examinations, peripheral blood smear examination. Coming to the differential diagnosis, as we know that there could be reactive and neoplastic proliferation, so there are these multiple causes which can cause transient proliferation or persistent being reactive, and in the neoplastic it could be actually acute neoplasm or a chronic neoplasm. And there was a study published in 2018 by Schlinger et al., and this was a very important point highlighting the significance of these hemocytomorphometry, where CBC derived parameters using these analyzers were evaluated to assess these monocytosis and their importance. So they established a scoring system and utilized quantitative parameters which included monocyte count, the neutrophil monocyte ratio, and the structural parameter NEWX to distinguish chronic myelomonocytic leukemia from reactive monocytosis. So to highlight this, NEWX actually represents polymorphonuclear dispersion in terms of granularity, and it is a highly sensitive parameter to identify the coexistence of minimal granular neutrophils and the normal ones. It showed quite significant findings when it was challenging to make the diagnosis just based on morphological abnormalities. And it was more efficient than the flag detected by the analyzer at times. So as per this important study, it actually made us wiser in thinking that how can they play a role in, helping us in differentiating a reactive diagnosis from such a neoplastic serious diagnosis. So using these three variables, a monodysplasia score was derived, which used NEWX, NEMO, and absolute monocyte value, and they found that a cutoff of 1.6, if it is more than that, with absolute monocyte count more than 1000 and 10%, they being more than 10%, there is a microscopy which should be done to assess the dysplastic changes in all the lineages. And if the value is less than 0.16, this favors reactive monocytosis as they found by the analysis. So this was another article which came later in 2019. And this was a hierarchical approach in the diagnostic workflow of CMML. And there was a role of the score combined with flow cytometry to quantitate the monocyte subset. So Zhu et al., they also worked on it and they associated these results with the flow cytometric findings. Another article in one of the latest in 2020, they also found, they correlated that this approach of diagnosis of hematological malignancy using this monocytosis workflow, optimization, and abnormal lymphocytes and blast flag, which we very commonly find in our CBC analysis, how important it is. So to just highlight, we know that monocytes, they can be divided into subfractions. Largely, there are three distinct populations based on the CD14 and CD16 markers. One is classical, non-classical, and intermediate, and they have different roles, which includes, which is associated with the distinct pathways and play a physiological role in healthy individuals. So classical, intermediate, and non-classical, based on their percentage, it can play a role. So after deciding the morphology and CBC findings, including the parameters, coming to the flow cytometry, this makes a very important part of monocytosis workup. We can highlight it here that whenever there is an infective or inflammatory condition, first there is an increase in the intermediate monocytes, and then it is followed by non-classical. So this is the diagram to highlight the flow of or the movement of monocyte and the role in the physiology in healthy individuals. And when there is a bacterial infection, the classical monocytes, which are higher in number, they are recruited and they go to the site of inflammation. They identify the pathogen and phagocytose them. There is a secretion of pro-inflammatory cytokines, and then other immune cells are recruited. While the non-classical monocytes, they display a distinct motility and a pattern of crawling through the vasculature, and that's why also known as patrolling monocytes. An important point to highlight here is that in CMML, there is a significant increase in this fraction of classical monocyte, which as per the literature has been found to be crossing 94% at the expense of rest of the two categories, that is the intermediate and non-classical, while in non-clonal monocytosis, it is because of the accumulation of intermediate and non-classical monocytes. So a pilot study was also carried out in our lab by the part of DRNB dissertation, where she worked on this utility of monoscore to diagnose hematological malignancies in patients with monocytosis, and here they found a cutoff of 0.22. So this score is actually derived from CBC. It is independent of the operator perception, then objective, and does not require a high level of expertise. Because of the high negative predictive value in these cohorts, this monodysplasia or monoscore, the peripheral blood film review rate was found to be much lower, like from roughly 6 to 7% to 0.5% without compromising the sensitivity. And it can play a significant role in the early diagnosis of chronic myelomonocytic leukemia, and it can also prevent the consequences, which can be very serious, including the hemorrhage and the infection. So the progression into acute leukemia can also be avoided. So to summarize, there has been a long list of differential, which comprises reactive and non-reactive or neoplastic causes, and the workup requires integration of clinical profile. Of course, we cannot underestimate the history and clinical workup, laboratory data, morphology, and ancillary studies. And these newer parameters, once integrated in this monocytosis workup pattern, including absolute monocyte count, it can play a very significant role as a filter in reducing the peripheral blood smear reviewing to reach a conclusion without compromising the sensitivity in the workflow. As per recent publication, in cases with isolated monocytosis, the flow cytometry can add more value to the morphology in diagnosing these cases of CMML. And once there is isolated monocytosis with an abnormal score, monoscore, it is strongly recommended to quantify monocyte subset by the flow cytometry. But not all the time it is possible to do flow cytometry. It may not be available. So in such cases, at least with the help of these CBC related parameters, which are of course not adding to the cost, but it can give a clue that these are the cases where it's worth spending more time and more careful peripheral blood examination and going for flow if it can be done. So to highlight a combination of monoscore, the morphology, and the flow cytometry, these cases can be detected, the CMML cases, as a blood-based diagnostic approach, avoiding invasive procedure like bone marrow to highlight dysplasia and all, in these cases with monocytosis. So these are the references, and I'll acknowledge my colleagues. Thank you so much.
Dr. Amrita Saraf.
Thank you.
May I request Dr. Bireen if there are any questions?
This is the parameter which the analyzer gives. So it is related to the granularity and the dispersion. So it's not something which, one can modify or one can assess. It's like a parameter which is based on its innate characteristics, which is there in the sample. And using this formula, if it is incorporated, it can help in assessing the score. It is something similar to that because it's based on the internal characteristics of the neutrophil.
Regarding the CMML, rather than it is better to think first of all the tuberculosis. Second, in any case of the CML, which is not a common findings, so better to go with the clinical features because I'm in the oncology setup since last 25 years, 30 years. So better to go with the clinical features like the splenomegaly and any generalized condition, etc. And one more thing in one of your study, what about the falsely elevated monocytosis after the chemotherapy? Any idea about that? Because in one of I think I used the Coulter for more than 15 years, and that was that particular parameter was giving the wrong result, or you can so highly falsely elevated. Any idea about that?
First, I would like to answer your first question, because here the cases which I have highlighted, it's to highlight the monocytosis. First of all, we can never undermine the clinical presentation. As a clinician, you have to first inform us with the relevant clinical history. Here I am highlighting what we get on our CBC analysis because I think all the lab people know how frequently we get the clinical details of our cases. Many a times we make an effort to find out, but it's not like we should ignore this. It's first to pay attention what exactly is the clinical presentation, and then if there are say other blast like parameters or other flaggings or say in other lineages, of course we should not think about a reactive proliferation, rather than we have to focus on that maybe this monocytosis is a part of abnormal proliferation of the myeloid series. And if there is a splenomegaly, if the clinical suspicion is of a neoplasm is there, we have to pay attention to that. Secondly, in a case of TB, here, like you saw first case where we thought of TB, I mean the clinician thought of TB, but it came out to be CMML. In another case, it was a known case of TB, but still it proved to be a CMML. So TB in our country can be, it can be seen in association with so many things, but sometimes it confuses us because knowing a case belongs to, a tubercular pattern, we start thinking, okay, this must be a reactive proliferation, which it is not. Like here, we know that in dengue, we all are, spending so much of time in peripheral blood smear examination, and even though HFLC and other parameters are helping us, but we spend so much of time in screening, and we are sometimes scared that we should not miss a lymphoma because of it is mimicking, the morphology is mimicking with that of an atypical lymphocyte. So we come across such cases, and here it's like same thing is applying to monocytosis, where we really don't know, whether it's truly fitting into a reactive one or not. But everything has its limitation. This is to highlight that as a part of CBC parameters, this can help us. And seeing this large study and this pilot study, it gives us a pointer that one can give importance to this score, and these parameters can give us some hint that, okay, maybe in this case, one has to look for the morphology. Maybe in another case, we can avoid it. So with a high workload departments and lab, this can actually help us. But I agree that in an Indian setup with so much of infections and inflammation, and almost round the year we keep on facing some or the other kind of challenging infections and all that. So we have to be careful. We cannot blindly just trust on this, and that's why the later studies which are published internationally, they have highlighted that even flow cytometry can add value to it, where we can see like how much is the classical, how much is the non-classical. So these all have their own importance, but of course we have to use them mindfully, and a combination of them can actually help us a lot.
And madam, what about the post-chemotherapy status? Because there is generally, that is my personal experience. What about your experience?
See, in post-chemotherapy, we have not used it, first of all, because we all know that as a part of recovery, we can see monocytosis. Here we are talking about when we are running it and we don't know the cause of it. Once we know the clinical detail and we know that monocytosis is there, we can keep an eye that, okay, this is part of the recovery and it's going to be fine. But sometimes, as a part of, without any details, it can help.
Any questions?
Yeah, please.
Yeah. I have a question that is, have you tried to use the hemoglobin, the anemia, and the thrombopenia as together with this monoscore or monodysplasia score for your detection? Because in my experience, it increased the sensitivity, the specificity of this flag.
Yes, it was done as a part of the thesis workup, but here I have not highlighted that part. It's just to highlight that how these parameters can be helpful. But yes, I agree what you are saying. The hemoglobin, the thrombocytopenia, the abnormal flags, they all play a role, and this can assist in terms of reaching to a diagnosis.
And now a comment, it's not a question, that we have experienced the neutrophil scatter, the neutrophil X, also is not only useful for CMML, it's also useful for myelodysplastic syndromes. Yeah. For this reason, in my experience, can be used not only for CMML, also for MDS.
Yeah, and they share certain features, MDS, MPN.
Yeah.
So definitely it is useful. Thank you.
Thank you, Dr. Amrita Saraf. So moving on to the next session, may I call on stage Dr. Shashank Mishra, and to chair the session, may I call Dr. Shabnam Ruhi. Dr. Shabnam Ruhi has 20 years of experience in her field, and she has received her postgraduate degree from KMC Mangalore. Her areas of clinical expertise include diagnosis of hematological disorders. She has been an assessor for NABL for the past 10 to 12 years. She has multiple certification in hematopathology and quality assurance. So,
Yeah, good afternoon. I think I will read out his introduction. Dr. Shashank Mishra has got an MD from Armed Forces Medical College, Pune. He has a total experience of 6 years after his MD. He's an assistant professor at Command Hospital, Air Force in Bangalore. Yeah. Assistant professor at Army Hospital Research and Referral in New Delhi from 2018 to 2022. He was an associate professor and HOD of pathology at 5 Air Force Hospital, Assam from 22 to April 22 to November 22. Currently, he is working as a senior resident at Gujarat Cancer and Research Institute, Ahmedabad, and the areas of interest are oncopathology. Welcome, Dr. Shashank Mishra, and over to you.
Thank you so much, ma'am. A very good afternoon to everyone. So, I'll be delivering a talk on the diagnostic utility of high fluorescence cells in serous effusions. As Dr. Simon has already touched upon the use of high fluorescence cells in detection of blast, so I'll be sharing my institute's experience in diagnosing malignant effusions. So, in our institute, we have the BC 6800 Mindray autohematology analyzer, which uses forward scatter, side scatter, as well as lateral fluorescence. As we know, forward scatter is proportional to cell size. The side scatter denotes the cytoplasmic granularity, and the lateral fluorescence is proportional to nucleus size. So, in this image, we can see a window which is above the monocyte window, where the lateral fluorescence is high. This is the window of high fluorescence cells. So, high fluorescence cells have a higher nuclear size than leukocytes. So they emit a higher fluorescence. As we know, malignant cells also have a large nuclear size, so they are counted as high fluorescence cells. In body fluids, we have two other important cells which also have a large nuclear size, which are mesothelial cells and macrophages. So these two cells are also counted as a high fluorescence cell. We did this study with the following aims and objectives. Our first aim was to compare the number, the absolute count, as well as the percentage of high fluorescence cells detecting using the body fluid mode of autoanalyzer between malignant as well as non-malignant effusions. Our second aim was to study the sensitivity and specificity of HFC for detection of malignant cells and to determine the ideal cutoff of high fluorescence cells for maximum sensitivity and specificity. We conducted this study in the Department of Oncopathology over a period of 6 months from July 2022 to December 22. Our total sample size was 209 samples, which included 112 pleural effusion samples and 96 ascitic fluid samples, and one sample was drainage fluid. We included all suspected and confirmed cases of carcinomas, sarcomas, as well as hematolymphoid malignancies in our study. We did a total and differential count of all the cases using the body fluid mode. Each sample was simultaneously sent to cytopathology laboratory, where the microscopic examination was performed on Papanicolaou stained slides using centrifuge samples. A cell block was also prepared in cases when feasible, and immunohistochemistry was also performed on these cell blocks when required. Statistical analysis was then performed using R software, and difference in high fluorescence cell count and percentage was assessed between malignant and non-malignant effusions. We used Mann-Whitney U-test to determine the statistical significance, and a p-value of less than 0.05 was considered as significant. Cases which were found to be positive for malignant cells on microscopy were taken to be true positives, and those which were found to be negative were taken as true negatives. Then we calculated the sensitivity and specificity of individual high fluorescence cell absolute count as well as percentage using the ROC curve. Optimal cutoff for sensitivity and specificity were determined as the cutoff with the highest sum of sensitivity and specificity and with the highest Jordan's index. In our results, we found that amongst all the cases, 129 were female patients and 80 were male patients. A total of 97 samples, that is 46%, were found to be true positives, and 112 cases were found to be negative on microscopy for malignant cells. We found that the most common primary site in cases of malignant effusions was ovary. The second most common was hematolymphoid, followed by breast and lung. We found that in malignant samples, the absolute high fluorescence cell count was significantly higher than in non-malignant effusions. For malignant effusion, the absolute HFC count was 25 high fluorescence cells per microliter. For non-malignant samples, it was just 5. Similarly, for HF percentage, we found that in malignant samples, the percentage of high fluorescence cells was 10.4%, and for non-malignant cases, it was 5.7%. This is the ROC curve, which plots sensitivity against 1 minus specificity. The blue plot is for the absolute count, and the green is for the percentage. So as we can see, the area under curve for absolute high fluorescence cell count is higher than the percentage. So we determined the optimal cutoff for high fluorescence cells. At a low cutoff of 30, we found a sensitivity of 68% and a specificity of 64% for detection of malignant cells. For percentage, at a cutoff of 27%, the high fluorescence cell count was found to be 74% sensitive at a specificity of 56%. When we increased the cutoff to 72 high fluorescence cells, the sensitivity came down to 48%, but the specificity was 83%, which is quite good. So, high fluorescence cells, as we discussed, have large nuclear size and show increased fluorescence. These malignant cells also have large size and are hence counted as high fluorescence cells. So we compared the number and percentage of high fluorescence cells in malignant versus non-malignant serous effusion, and we found that there is a significant difference in the absolute count and percentage of high fluorescence cells in malignant effusions versus non-malignant effusions. The ROC curve has demonstrated a sensitivity of 68% and specificity of 64% at a low cutoff of 30. Amongst these cases, a total of 30 cases were found to be false negative. Then we reviewed all these cases and we found that the cases which had a lower percentage of malignant cells, that is only occasional cells were seen on microscopy, were found to be false negative because they had a lower percentage of high fluorescence cells because of a lower number of malignant cells. At a higher cutoff of 72, the specificity was 83% and only 18 cases were found to be false positive at a high cutoff. So these false positive cases were found to be having a high number of reactive mesothelial cells on microscopy. So to conclude, we have found that there is a significant difference in the number and percentage of high fluorescence cells in malignant vis-a-vis in non-malignant effusion. We have in our experience, high fluorescence cell count is a useful ancillary technique, especially in high volume center like ours, where there is a significant cytopathology workload. So, high fluorescence cell count is an useful aid to the cytopathologist, and it gives a clue about the probability of finding malignant cells. If the high fluorescence cell cutoff count is low and you are not finding malignant cells, then you can easily give out a negative report. But if the HFC count is high, then you have to be very sure and you have to spend more time on the slide before giving out a negative report. These are my references. I thank you for your time and attention.
Either they are malignant cells or they are mesothelial. They generally come in clusters. And meso have more large clusters compared to our hemat cells or malignant cells. So how this counter counts the clusters? Because what we focus is on single cells. when it comes as a big cluster.
The exact algorithm, sir, I am not aware, but as a cluster, I don't think it counts it as a single cell because the cell count, that cell size or cluster size is too large
Because
to
those
be counted.
clusters can be even a hurdle in my flow also. If I run it on a counter, it can even block the passage as well. So how you overcome that problem of clusters? Because cluster can be right from 2 cell or it may be 10 cell or even 20 cells.
Yes, sir, you're right, sir. Currently, it counts single cells only. The clusters are not counted. Currently, there is no way to dissociate the clusters into individual cells.
I have another question regarding the same thing what sir asked.
Yeah.
So in my study, I'll be presenting my data tomorrow. I have experienced false negative cases which are fed into the Mindray analyzer. We have BC 6000, 6200. So in that, I have come across 4 false negative cases where there were malignant cells in the effusion, but they were present predominantly in sheets and clusters. So it was a false negative diagnosis by the analyzer, which was not flagged for high fluorescent cells. So I actually would like to ask others' experience regarding the same because I'm getting false negative cases in this.
Even we have the same issue, right? When the cells are in sheets, no, it's not able to get it.
It is not diagnosing
And,
at all.
it's not
actually.
I
diagnosing.
think the equipment does not count the, it depends on the
It
size,
is
so it will
it
not
is
count the larger
when,
cells. Yeah.
when it is in a clusters of cells,
It will
it
count
will
as
not
a
count
single
in a-
cell.
The sheets are not counted.
Not counted.
So there should be some solution for this from the whatever the technology side where they will help us with dissociating these clusters into singles which can be just fed because just similar to autoimmune hemolytic anemia where the clumps of RBCs cannot be counted in the analyzer. I explain it in the same way. These clusters and sheets are also not taken into account and probably the fluorochrome, whatever we use in the red channel, will not be able to penetrate the cell clusters and sheets. So we do not have a high fluorescent area which is...
I think Dr. Simon has an answer to that.
Okay.
Yes.
Let me explain you the purpose to have high fluorescent cells for cancer. The thing is, when you have a lung cancer, that sometimes is for years, that has been growing slowly with low Ki67, low duplication rate, will be very low high fluorescence. If these cells invade the pleura and come through the pleura and you can detect them, they will be very low high fluorescence. Normally, the high fluorescence comes when the cells are very Ki67 positive, the duplication rate is very high, and are more aggressive. This parameter is not made to decide cancer or not cancer. Is helpful when you have doubts in the morphology, that you don't know exactly what is that because it's not so clear, and you don't have immunohistochemistry or you don't have special markers. In this case, is when it's very useful because the instrument gives you another parameter. It's like the relation nucleocytoplasm, automated relation nucleocytoplasm. Is related to the size of the nucleus in relationship with the size of the cell.
Okay, sir, but actually the false negative cases I spoke about were the cases which were proved on microscopy because we compared all the cases in the analyzer as well as microscopic examination of all the 3 stains, H&E, PAP and GIMSA. In all 3 of them, there were very good malignant cells and the case was a known primary malignant tumor with secondary metastasis. So this is the actual result that I've got in the study.
No, and as you have seen in the study I presented that was in ISLH, the detection was not perfect. It was about also 0.7 is not perfect. You miss 30%. This is not made for the detection of, because for the detection you need a ROC curve of 0.9 or 0.85 or 9. 0.7 is just to help the morphology to have a better, it's like a help. But
sir,
what is clear is the Mindray artificial intelligence is higher detection than Sysmex. That is what I presented. But it's still not enough to decide positive or negative.
And I have come across cases which are false positive, where HF percentage as well as absolute is higher in non-neoplastic effusions with more than 30%, but that is, I'll be presenting the data tomorrow, so that is the total count and HFBF cells are low, very low in that. So it is giving a false high fluorescent cell count in low count effusions.
Yeah, and I recommend to use this parameter, high fluorescent cells, together with the CEA, other tumor markers, and the
False
ferritin.
positive, usually we will be able to make out because we will know the clinical history of the patient. We will look at the cells as such.
And the clinical.
False negative becomes a problem because we might not screen the slides. When it is false positive, we will definitely screen the slides.
But I recommend to use tumor markers, the
Yes.
clinical features, loss of weight, loss of, it's a parameter that is helpful, but not alone, together with all and it's helpful when you have gaps in the morphology.
Even in our study, ma'am, the sensitivity and specificity was around 65-68%. So it's not a sensitive enough test to be used as a screening test. The final say is microscopy only. So anyway, we'll have to screen the slide. But it's just an aid rather than a replacement of microscopy.
Rightly said. I think what I derived from this talk was we have to see the smear. Slide is important. Our microscope is important. Only if we have doubt, you go back and see if the HFC is elevated or not. So that I think should be the take-home message, that microscopy is still the gold standard. Any more questions? Yeah. Thank you, Dr. Shashank.
Thank you.
So without much delay, I would like to introduce the next speaker, who is Dr. Boniana George. And she has done her MD Pathology from Christian Medical College, Ludhiana, and then a postdoctoral fellowship in Lab Emerge from Christian Medical College, Vellore. And currently, she has a designation of Assistant Professor in Department of Path at Believers Church Medical College. The podium is handed over to you, Dr.
Very good afternoon to all of you, and greetings from Believers Church Medical College, hospital in central Kerala. So I'll be presenting on high fluorescence lymphocyte count, morphology in dots and numbers. It's a compilation of observations made on a patient data set over the last 3 months, where we had an increase in acute febrile illnesses in our hospital. So when we think of viral illnesses, we hear the terms atypical lymphocytes, reactive lymphocytes, transformed lymphocytes, or virocytes. And usually it supports viral infection, and its morphology is distinct from the normal. There's heterogeneity in shape, size within the same sample as well as between samples. Now we have learned the Downey classification of lymphocyte morphology from type 1 to type 3, but from the clinicians, and then comes the plasmacytoid lymphocyte, which has features similar to a mature plasma cell. Now, I will not go through the principle of the fluorescence technology. It has been highlighted by different speakers. But my talk is centered on the HFC, which reflects the high fluorescent cells that have taken up the fluorescent dye, and it shows up as a separate population because of increased fluorescence due to RNA content. Now, a lot has been already known about HFC. Studies have been done in the context of infectious illnesses where HFC was high in dengue fever. Several studies have done it, mostly I think on the Sysmex platform. And I think a few studies has been done by in BLK Kapoor Hospital. So I have listened to those talks by Dr. Anil, and I have read the articles from there. And this is also, they talk about in the context of HFC in dengue. Along with that comes the typical scatter pattern, which we heard as the tilted hourglass or the figure of 8. Now, why did we decide to look into this in our hospital is because clinicians started, randomly calling, like, can you tell us what the IPF is? And it would stop there. They wouldn't even ask, like, is it significant, or till when will we wait? Does it actually change anything in their, in their management? Then some of them came up to us asking, do we have HFC here? Can we do an article? And this is mostly the mid-level faculty who probably are in line for a promotion and they want some research articles and something, can be easily done with less effort. Then from the laboratory side, what we faced were fever with thrombocytopenia with the typical dengue scatter pattern and HFC values, which turned out to be not dengue, or they just stopped the analysis with dengue NS1 antigen or the card IgM IgG. They didn't pursue it with a sensitive platform. So we never knew whether it was truly not dengue or not. So we looked into this. So it is a pilot study, an observational study, 1 month prospective, 2 months retrospective. We took cases of acute febrile illness, the infectious group, and the non-infectious causes of atypical lymphocytosis. So we wanted to see if there's any correlation with the morphology with HFC, and if you can differentiate the various causes by looking at HFC and scatter pattern, and also if we can determine a lab cutoff to distinguish dengue from non-dengue cases. So this is the 171 cases that we had and the split up. Most of it were dengue, and we had leptospirosis, infectious mononucleosis, H1N1, few cases of malaria and scrub, but I have not included the analysis of scrub in this talk because the scrub results that were coming, most of it were like, people, even the microbiologists were like, it could be a cross-reactivity. And the cases that were indeed followed up with a DNA PCR all turned out to be negative. So I have not included that. So we had a total 73 cases of dengue, and the ones which had an NS1 positive were 65 cases. So in the first sample, we just looked at the first sample that came to our lab, that is of patients with a febrile illness less than 10 days. First sample, we took the mean of the HFC and it was 4.95. When compared with normal controls, it was significantly higher. And this was the various patterns that, this is a pattern that we saw with varying degree of HFC percentage. Now, morphology-wise, it was predominantly the type 3, but we would see type 1 and type 2. It was mostly the bluer and the more immunoblastic type. Now, 8 out of 73 cases, when it was NS1 antigen and IgM IgG by card was done, it came negative, but it was positive on the sensitive platform. In these cases, our HFC was high and the typical scatter pattern was there. So when we saw this from the lab side, and we saw that the NS1 antigen and the card IgG, IgM came negative, we had asked them to follow it up with the alpha because we went by the pattern and the HFC. Now, we just, out of this 73, we took out a small subset, which is 24 patients with severe thrombocytopenia and had minimum 5 serial values for monitoring to see about the platelet recovery in relation to HFC. And we noticed that most of the patients, most of the cases showed a platelet recovery within 24 to 48 hours. Now, coming to the next group, 23 cases of leptospirosis, it didn't have a very significant high HFC. In 2 cases that was showing very high HFC values, the first one actually had a complicated illness and severe thrombocytopenia, developed shock. So he had a more, it was a more morbid condition. And the second case was a case that had a dengue NS1 positive outside, and in our hospital it was negative and leptospira serology came positive. So I don't know whether it's cross-reactivity or it's a dual infection here. Infectious pneumonucleosis, we had 14 cases. Here we had a higher HFC, but not as high up to what we see in the dengue cases. And this is the various patterns that we noticed on the scattergram. And coming to the morphology, it was predominantly type 2 cells, though there was few of the type 1 cells too, morphology cells. 27 cases of H1N1 was analyzed, and we got an HFC mean of 0.68, with one case that went up to 4.5%. And this is the morphology that we saw. It was varying between type 1, type 2, and type 3. And this was the case of H1N1 infection with the high HFC of 4.5%. This patient developed over the course of his illness, he developed multiple problems and he went into sepsis, septic shock. He had serial drop in counts, and so his course of illness was severe. So, so this made us think that those patients who don't do well, who actually develop a severe illness, it is reflected in their HFC count, though this has to be evaluated in a larger group of patients. Now, in malaria cases, we had a mean HFC of 1.5%, higher than what was seen in normal, but not as high as dengue cases. I've just highlighted a few. Some of the cases were mixed infection, ring forms, and the HFC varied from 0.4 to a high of 3. And I kind of noticed that there was an inverse relation between the HFC and the infected red parameter that comes on the Mindray, so which made us think that maybe when the immune response is more, the parasite load comes down, if that can be taken or understood from this. So the next group where we were getting fever, thrombocytopenia with reactive lymphocytes was the next group was the autoimmune disorders group, which there were cases with fever, thrombocytopenia and reactive lymphocytes. And this is just a tabulated profile of these patients. 3 of them were diagnosed cases and they were on treatment, and they presented with either bicytopenia or thrombocytopenia, and the HFC values range from 0 to 0.8, not that high. But then we had another 3 patients who were diagnosed it was an acute presentation of the autoimmune disease in the form of recurrent oral ulcers, alopecia, SLE, or a rheumatoid arthritis with severe symptoms. So in these cases, the HFC percentage was found to be higher, ranging from 3.2 to as high as 11.7. So I am just highlighting this case. It was a young male, a 28-year-old male patient, and we got the CBC. It was showing thrombocytopenia. There was, it was mild thrombocytopenia, but there were a lot of reactive. This is the spectrum of lymphocyte morphology seen in this case. It was all over the place. And when we looked into the scattergram, it was showing the typical figure of 8 appearance with a high HFC of 11.7. So when at the first day we were telling, please evaluate for dengue, exclude that, and the clinician did perform the dengue testing for the dengue, and it came negative. We told him to pursue with the sensitive platform alpha, and that also turned out to be negative. Meanwhile, over the course of the next 2 days of this patient, he developed skin lesions which was quite diffuse and erythematous. And they had a query of SLE, which is actually quite rare in male, and they worked up with an autoimmune profile, which was showing a pan-reactive panel. So the diagnosis was acute flare SLE with myositis. And here we got a high HFLC count. And in an ITP newly diagnosed before treatment started also, we see the same pattern with a high HFLC count. Now, coming to the non-infectious group, there was a total of 26 cases which have been segregated. Bulk of it was the CLL. Here, the HFC was not that high. We had 4 cases of hairy cell leukemia. Again, the HFC mean was not high. 1 case of adult T-cell leukemia lymphoma, HFC not high. And Burkitt's leukemia, which couldn't show any differentiation on the scattergram, no value. 3 cases of multiple myeloma, which had plasmacytoid lymphocytes in the peripheral blood. This was the morphology seen in our cases. And the HFC pattern, it ranged from 0.5 to 1.1. And we see plasmacytoid lymphocytes in the peripheral blood. There was 1 case who was a relapsed myeloma, and she had plasmacytoid lymphocytes in the peripheral blood. But her course of illness, she had developed sepsis and she expired. So all these findings based on our observations. In the infectious group, dengue has shown the highest values, but in the non-dengue cases, if you see high HFC values, it would suggest that there is the symptoms are more and the course of illness is high, like in sepsis, and the morbidity is higher. So we have a central laboratory concept. So the microbiology sits just opposite to us. So whenever we see these patterns, we go and correlate with microbiology results. And when they saw that we would tell that it was dengue before they even do the test, they approached us because they had an ongoing project for finding out the serotype of the dengue in our area, dengue virus in our area. So the problem they were facing was that the sample, they would like to identify them as fast and rapid as possible so that they can extract the RNA and before the dengue virus clears off from the system and before the sample tests positive after the clinician request. So this is how we have been using this HFC and the scatter pattern. And also in the autoimmune cases, those who present with acute flare or that acute disease manifestations have a high HFC, and if it's controlled, it comes down. So a potential for monitoring response to treatment can be considered. I mean, this would be, we would like to study a larger cohort in order to, make sure that these findings have any relevance. Thank you.
The reactive lymphocytes that you see in viral infection, they are not B cells. They are T cells. Isn't it? And you are talking about plasma cells, which are B cells. Activated B cells are plasma cells. So they are not seeing in B activated B cells. They are seeing only in the activated T cells. The downy cells are T cells. They're not B cells. Infectious mononucleosis cells are T cells, not B cells. So that question, needs to be a little modified in the sense that you wanted to know whether in the activated B cell, do you see high fluorescence cells or not? Is that what your question was? Or?
Practical experience regarding this because the DXH 800 or 900 doesn't give this HFLC, but I was going through this high fluorescent lymphocyte count, and there is some data on Sysmex XE series which says that the B atypical lymphoid cells and the plasma cells correlated more with HPLC rather than the activated T cells, and in that study they included the infectious mononucleosis where the reactive lymphocytes are mostly CD8 positive T cells and that didn't correlate with HFLC. So there is one or two published.
Yes, can I make a comment on that?
So, ma'am.
So the thing is that we had done a study on dengue where we correlated the lymphocyte increase and the HFC, and we compared it to the flow cytometry counts to again prove a point whether the activated cells or the high fluorescent cells are they B cells or the T cells. So we found that actually it's a mix of B and T cells. It's just not only B and the plasma cells. So if sir is right, actually it's a combination of B. So all of them are actually coming across as high fluorescent cells. Though in the literature we have always studied that it is actually the B cells or the activated B cells. But in our study we found that it is actually not just the B cells, but a mix of B and T. More T's. Actually, yes. Yes, I would agree. Yes, absolutely. Huh? Absolutely, sir. So you're right, actually, more of T, but clearly a mix of B and T.
Ma'am, yeah, we had those cases of autoimmune disease which had the high HFC. So in that case, it would be a B cell stimulation.
Yes, absolutely. It seems like that. It should be like that. But again, you have to correlate. If you have a cell sorter or something, you can sort out those cells and then do a study on them. But otherwise, it's tough to say. Sorry, sir? Yes.
Yes, ma'am. 11% I had in one case. That had a higher HFSC. But then whether that's what plasmacytoid lymphocytes, plasma cells, I don't know how much, like those mature plasma cells, not same. But I've noticed that.
So maybe that might be the reason why you are getting an HFIC which is not high. So did you try to correlate with the numbers?
I will look into it.
You can do it.
Yes.
When, can I make a comment?
Yes.
When you suspect plasma cell leukemia, there is a very simple test that can be done in the routine lab. It's just to mix the tube of the CBC and to put it in vertical in a rack or in any surface. And in few minutes, you have a high sedimentation rate that you can see that even in the hematological tube, you can see that in 15 minutes, you have the red cells are sedimentated so fast, and it's quite easy if you have suspect of plasma cell leukemia. Of course, if you are a good morphologist, you can see them. And if you have flow cytometry, better. But it's a simple test that can help for the diagnosis of plasma cell leukemia or myeloma.
Thank you very much, Dr. Boni. May I call the next speaker, Dr. Anuja Chopra, and the session will be chaired by Dr. Ramon.
Yeah, Dr. Anuja Chopra, she has completed her post-graduation from Kasturba Medical College in Manipal. She's trained in oncopathology from Bhakhan Mahaber Cancer Hospital and Research Center, Jaipur. She is also trained in hematopathology and flow cytometry for Rigshospitalet, Copenhagen, and in cytogenetic and molecular medicine from Institute of Molecular Medicine, University in Copenhagen, in Europe, okay? She has done a lot of research in genetics of asthma, infertility, achondroplasia, and brachydactyly. She's trained internal auditor as per ISO, etc., ISO. And certified Six Sigma Black Belt. Wow, this is near perfection. Thank you for coming here to share your experiences.
Thank you so much, sir, for your kind introduction. And I would like to thank the organizers for the opportunity to share some of my experiences. Now, what I would be sharing is what we as small standalone labs face when, you're sitting amidst general practitioners or family physicians, as they call themselves, who want everything on a CBC. And we have very minimal support of any specialized investigations because the affordability comes as a major factor. So I would rather put it as, when you have more sensitive and specific diagnostic tests available, the basic tests are actually losing their sheen. But when you sit as a standalone lab, you face all those problems wherein everything narrows down to the pathologist and you're expected to give a diagnosis just looking at the CBC smear. So the problems that we were facing was, during the dengue, chikungunya season. Now, both are vector-borne, both present very similarly, and the differences don't really appear in the early 48 to 72 hours. It's only later after, say, third day or something, patient comes up with severe joint pains, and their diagnosis can be made if the specialized tests are not undertaken. The first, the problems that we face is that, the symptoms are very similar, and in chikungunya, now the first 5 to 7 days, there is no serological test that can detect the virus. The only answer is PCR, which is practically a difficult thing when you start dealing with finances. Dengue, we do have NS1, but a lot of false negatives also we did get because they insist on doing a rapid test and not even an ELISA. The third thing in the same season that we come across is the typhoids, wherein again the first week none of the serological tests come positive. So since we did not have access to the specialized investigation for most of our patients, we started looking at the CBC pattern carefully, and something odd that appeared was some of the tests, some of the patients had neutrophilia. Now, in a season of viral infections, finding neutrophilia was odd, and then we started looking at the neutrolympho ratios, which were considerably elevated. Now, CBC can really be of use because we have the basic ratios that can be calculated from a simple CBC. So the neutrolympho ratio calculated either using the absolute counts or the percentages can be handy. Only problem is that there is an effect of stress on NLR, because the moment the body is exposed to stress, there are a lot of endogenous catecholamine release, which increases the neutro and decreases the lymphocytes. Plus, it depends on the clinical context, wherein we presume that a normal NLR of 1 to 3 is considered a normal. 6 to 9 could be a mild stress, and 9 or higher would be seen in critically ill patients. Increased levels of cortisol do cause an increase in neutrophils, endogenous catecholamines, and cytokines. They all cause increased NLR. Now, the utility of NLR is not solely as an indicator of infection or inflammation. Any physiological stress can alter this parameter, and it increases very rapidly following acute stress. So, we need to make use of the body's response. Now, what happens in chikungunya is that, the mosquito bite induces a neutrophil activation. NLR has not been, I could not find much of data related to chikungunya, but it has been studied in many other conditions, and every condition, specific cutoffs have been identified, and they have been defined so that, the risk and the prognostication can be done. Inflammation that occurs actually causes the neutrophil recruitment, and that releases the chemotactic factors. Now, this has been used as the marker for septicemia and critical inflammation, wherein the ranges have been defined. Now, a normal NLR is considered to be 1 to 2. More than 3 and less than 0.7 is definitely considered pathological, and 2.3 to 3 may serve as an early warning sign. For many conditions like cancer, atherosclerosis, infection, inflammation, psychiatric disorders, and stress. Similarly, we have a platelet lymphocyte ratio that we have been observing. Now, this is calculated as absolute platelet count to the absolute lymphocyte count. 95% reference range of 36.63 to 172 has been considered normal. Now, in chikungunya, there is the neutrophil extracellular traps are not documented. So, it is not the neutrophil extracellular traps that start working. What works is the TLR7 activation, which releases the reactive oxygen species. And there is a decrease in IL-8 levels, which is ideally supposed to lower the number of neutrophils and increase their numbers in skin. But actually, what we practically observed was something slightly different from what has been reported in earlier studies. Then a neutrophil stimulating factor has been reported, which is released by the mosquito saliva, and that activates the neutrophils, and that causes neutrophilia in these patients. Now, the other chemotactic factors also come into play, and then the mosquito saliva also causes mast cell degranulation. So what we did in this was we started closely observing the CBC trends and started making a retrospective comparison of all the chikungunya PCR positive cases with their CBC findings, because what we were observing was there was a neutrophilia that was a common factor in most of the chikungunya PCR positive patients, and platelet counts were definitely not falling. So NLR and PLR both were studied, and retrospectively we did a t-test, a chi-square test, and a logistic regression to see how we can study the impact of chikungunya on these factors. And then the R-square was calculated to see if there is actually a significant association. And lastly, we did a multivariate analysis where we compared our NLR and PLR simultaneously with our control group. Now, as such, in our patients in chikungunya, a mean of 9.5 NLR and PLR of 361 was reported, which was much higher than what has been reported as normal. And the percentage of patients coming with this was very high, that is 92% of our patients were actually having a very high NLR. Similarly, PLR was high in 88% of our patients. Then a T-test was run and the values were found to be significant. We did the calculations were done and a predictability of 91% was observed. Similarly, for PLR, it was 86% consistent with our hypothesis that there could be an association. Then a chi-square test was done, grouping the data based on the normal ranges that had been identified and defined earlier. This was not based on the data on our lab findings. This was done based on the defined ranges, and chi-square tests were significant. Then a positive predictive value was calculated, and a positive predictive value of 96% was obtained for NLR and 75% was obtained for PLR. Now, all this indicates that NLR and PLR both have a very significant association, and then the R square was calculated. Now, this R square is basically as close as it is to 1, indicates a higher association with the disease, and NLR was 0.845 and PLR was 0.685, which meant both of them could be used as predictive markers to at least advise a higher test. But smaller things have a bigger impact. When we did a multivariate analysis, the PLR was not significant because the p-value in this case in the multivariate analysis came to be 0.963 and a significant value is less than 0.05. So that meant that it's not just one parameter that affects it. There are multiple things that play a role in the body, and I did go through the literature, and I found that the interaction of platelets with the T lymphocytes reduces the lymphocyte proliferation, and that decreases the pro-inflammatory cytokines, and that has an impact in reducing the influence of PLR as a predictive marker. So individually considered, they are both predictive markers, but practically when an individual is considered as a whole, the role of PLR is much lesser as compared to NLR. The multivariate analysis was definitely a better eye-opener for us, and NLR was a more sensitive and predictive marker for taking into consideration. So now the NLR and PLR have a role, but when considering the individual as a whole, we need to look into further research that goes on, and definitely to be considered in concordance with the other clinical parameters of the patient. So an alert mind and a keen observation can help in directing the clinician to advise a specific test rather than requesting for a combo of the prevailing diseases, and definitely nothing can undermine the sensitivity and specificity of the specialized tests that are available, but definitely this is a boon for people who are fighting with resources to get a diagnosis. I had shared 115 cases, out of which 70 were from my lab, 27 were from Dr. Gaurav Agarwal's lab. 18 from Dr. Anshul's lab, that is lab expert, and a special word of thanks to our statistician, Dr. Neha Shroff, who helped us out with the statistics. Thank you.
I have a comment for you.
Yes, sir.
I am used to do logistic regression, and in this case, because both parameters are divided by lymphocytes, I recommend to use an NLR and platelets with logistic regression, or PLR and
neutrophils.
Yes, absolutely. And try that. And also, the third experiment is to try platelets, lymphocytes, and neutrophils in logistic regressions to see which formula it proposes you. The
Individually, they are all significant predictors. This is what we observed. But practically, PLR had hardly any significance because PLR was normal in all the cases, and even the control group, we had a lot of normal PLR patients. So that is why, the multivariate analysis actually rejected that possibility of it being a predictor.
Yes, this is the reason I make the comment, because I think both parameters have very good utility, but maybe to combine them is better to eliminate lymphocytes from the second one. And that is what I propose you to do.
Sure, sir.
And maybe you will share your results with us. Thank you.
Sir. Yeah.
Thank you. May I invite Dr. Jairam and Dr. Dhruv Mamtora will chair this session.
So, good evening, everybody. So, Dr. Jairam Iyengar, firstly, he needs no introduction. I think everybody knows him, but still, I'll introduce him. So, Dr. Iyengar is MBBS from Osmania University, Hyderabad, and MD Pathology from PGI Chandigarh since 1987. He's silver medalist. Also, he's a winner of Excellence in Teaching Awards from JNMC Belgavi, and he's a winner of several national awards. He's a member of various national and international associations and has presented many associations of India, and he's a member of Accreditation Committee to NABL and Chief Faculty for Foundation of Quality and Program Coordinator for NewCap EQUAS program, and has over 42 publications. So he has also delivered over 250 lectures. So we are adding one more to that. So welcome, sir.
Thank you very much, and a very good afternoon to you all. I think I am the odd person out in this session because perhaps mine is the only non-hematology talk, and in these 15 minutes, I'm going to talk about something that all of you already know. I'm going to talk to you about policies which are statements of intent and addresses the question what, and of course objectives which are means by which the policies are fulfilled. And these objectives could be multiple, which are directed to achieving whatever is stated in the policy. These need to be measurable, they need to be achievable and aligned with the policy. And the talk of mine today is about the quality indicators, which are nothing but analysis of the data which is obtained when all these objectives are carried out and they are fulfilled, to know whether we are in line with what we set out to achieve and whether the entire purpose is satisfactory or not, and the path for continual improvement is set once these quality indicators are diligently measured. So we'll try to understand very basically, very macro level, we'll understand the what and the why and the how of quality indicators or key performance indicators. And in the current context, everything is risk-based. The ISO standards have moved from process-based to risk-based activities. So let's try to see how we need to realign our quality indicators towards the risk-based approach. The quality indicators, I will not go through the definition. Quality indicators will measure how well an organization meets the needs and requirement of the users as well as the quality of all the operation processes. Why do we need to define and why do we need to measure, analyze these quality indicators, especially in the context of modern laboratories? We tend to achieve more with less. So the providing high quality results rapidly, providing high quality results with minimum expenses seems to be the goal of each one of us in the audience. And very small inefficiencies in the entire process can take up the costs. They can prove to be very expensive. And in this context, quality indicators play a very important role in the improvement process. Improvement not only financially, but improvement in the overall quality of the laboratory. When we actually set out to select quality indicators that we need to monitor, and we would probably make a big list of quality indicators that we would want to monitor, and somewhere we get lost in the entire, the volume of the data which is going to come in, the number of parameters that we are going to analyze. So certain key points we need to remember when we need to select quality indicators are the needs of the customer. Are we focusing our quality indicators to meet the requirements of your customer, to meet the requirements of your society? We have an obligation to the society. And of course, our own weak points, our strength, when we do a SWOT analysis, our own weak points, the vulnerable areas in the laboratory need to be focused, and you need to develop quality indicators towards that. And then these quality indicators will also depend on the resources that are available in the lab to achieve these indicators, to monitor the indicators, obtain the data, and so on. And of course, all quality indicators need to be aligned with the policy or the mission of the organization. Now, broadly, if you look at these, some of the quality indicators are required by law, by regulation, accrediting organizations, and contractual requirements. Now, most of the other quality indicators are chosen by the leadership or the management of the lab based on the organization goals, based on risk, based on strategic planning, review of data of whatever we have had, as well as review of the complaints, again gives us the areas that we need to improve upon, client feedback, and also subjective assessment. Some of these quality indicators are, again, the management should take a broad view of the operations, considering known risks and potential consequences. So we are trying to align ourselves to a risk-based approach to the quality indicator, entire analysis, and so on. And on a broad scale, I think every aspect of laboratory services should be objectively and regularly monitored at some point of time. And if you look at the CLSI guidelines, there are about 12 the quality system essentials that are defined, and we need to focus on various of these areas and shuffle them to see that all of these get monitored at some point or the other. But then when we select quality indicators on a priority basis, we need to consider a few of these points. One is this a critical examination? If it is critical, that takes high priority. If it is a very complex activity with many inputs, and a classic example is turnaround time. Everybody talks about turnaround time. Actually, believe me, monitoring turnaround time is a very complex process because there are so many inputs which are involved, so many timestamps that are involved. And getting an ideal data analytics of the turnaround time is always going to be a very complex task. So that takes priority. Everybody requires the reports on time. So we need to analyze that. Then if a process is highly automated or is it a manually driven process, that may help you choose certain quality indicators. then our own weaknesses. Is there something that is vulnerable and known for repetitive problems? In my own lab, I know that day in and day out, we have patient registration problems, the demographic errors as something which is repetitive. So are we monitoring those things? And then if we've already brought in certain improvements and we need to monitor to see whether those improvements are effective, that could be one area where you select certain quality indicators. So broadly, if you look at pre-examination, examination, post-examination, your quality indicator should span across all the three processes. And we need to apply risk management tools to narrow down this huge list of quality indicators that we've listed out to those which are more meaningful, and in that current context, they are the more important ones. That is what we need to focus upon. And all these quality indicators, I keep repeating, should align with the organization goals. So the key points here is do not select too many quality indicators to monitor at a given time. You may list out a lot of them, but select the few which are very important based on your risk assessment. Do not chase wasteful quality indicators which are not going to give you any meaningful information. And if you find that a quality indicator is stable, do not chase that stable quality indicator. Do not ignore it completely, but do not actually focus upon it with all your, the resources and so on. Now, I don't know if you can read this, just to explain, there are a few publications which have kind of developed certain harmonized quality indicators, which makes life relatively easy for laboratories. So they have developed a whole list of harmonized quality indicators, which are in the pre-examination, examination, and the post-examination areas. Now, it does not mean that every lab has to take all these harmonized indicators and start monitoring them. Now, in a given activity, among the list of harmonized indicators, one lab may choose a few of them, again, depending on how frequently those are contributing to errors, or what is the impact of that error on patient safety. So if you look at one example, I think this is out of focus. If you look at one example, the inadequate volume of collection was found to be one of the causes for a pre-examination error. Among the list of 3 or 4 potential indicators, that was found to be more often found. So that was monitored by the laboratory and they brought in the necessary corrective measures. So that's what this entire fishbone diagram wants to achieve, that whatever the list is there, you pick out those which are relevant to you. So indicators broadly can be of broad categories. I think this we have already covered. They cover critical processes, they cover quality system requirement, or those that are mandated by accreditation bodies. What is important is selection of quality indicators with care so that time and effort put into them is not wasted. The whole list of indicators which are there, all of these need not be monitored at a given point of time. So once you are identifying a quality indicator, we need to develop the quality indicator monitoring process, for which you take one of these, each one of these, and then you define the purpose of that quality indicator. So identify the quality indicator, identify the scope, identify the purpose, bring in the authority, bring in the list of people who are authorized to monitor these indicators, and which domain or which department needs to be defined. So this gets into a formal kind of a documented process. Once that is done, data needs to be collected, data needs to be analyzed, and you need to develop a strategy for analysis and collection of data, because ultimately data collection is the key to a good quality indicator process. So you collect garbage, you're going to get garbage out. So good data collection is the key. So you need to have a documented process for data collection. You need to bring in responsibilities, define frequencies of monitoring, define the source of data and the type of data. These are very critical things which give a good quality indicator monitoring. And what is the scheme of sampling? How do you sample the various things? Then setting targets is very important, because you need to look at a goal, you need to work towards that goal, and the limits and action threshold. So if it exceeds that target, what is the action we are supposed to take needs to be defined. And this will be based on current performance, will be based on references, and these targets should be feasible, they should be achievable. Let's not be idealistic and set very high targets that we may not achieve. That demotivates the staff. Set targets that can be achieved. I'll run you through some examples of, actually these are actually being done in some lab recently which I had audited, and the indicator here they've taken is the amended report. What do they say? The objective is to monitor frequency of the amended report. So that is very clear statement. What is the purpose and what is the rationale? The amended reports need to be communicated to the patient because treatment can change if the reports are amended. Now, how data is collected is defined. What is the measure is also defined. Percentage of amended reports. The frequency of monitoring is defined and benchmark is defined. The targets are defined. So this is how very clearly the purpose and the process is defined. Similarly, if you look at a CBC report, turnaround time for emergency lab and stat reports, similar kind of a process is followed. Very clearly, the people are aware of what needs to be done, how it needs to be done, who is going to do it, at what frequency it should be done, and so on. And what is the acceptable target. So once this is done, it is always good practice to do a trial run, do a short pilot study and review the results of that trial run, and then once you're satisfied, launch a full-fledged program. And collection of indicator data is very, very important. Once this data is collected, this data needs to be represented, needs to be interpreted and analyzed, and once it is analyzed, the data needs to be presented. And this data, once it is presented to the management will be able to take various decisions based on what is the outcome of the quality indicator data. So if you look at this, the tabular column of sample rejection, how many samples were rejected, percentage of samples rejected, listed out. So these are all listed out. A benchmark is also defined, and this is always a better appreciated thing, that you have a graphic representation of the quality indicator data. But the story did not end there with this lab. Even though they have achieved the target, the lesser number of rejected samples compared to what is their benchmark, still they split it. And they found that insufficient samples exceeded a benchmark, exceeded the cap benchmark. Similarly, they found that leaked tubes exceeded the benchmark. And then they tried to analyze it further to see from which of the collection points were these more often seen. And then they start plugging them. So that way, if you do that kind of analysis on a micro level, you can target the potential areas of problems and you sort them out. And then action plan, no action plan required. So what would be the action plans required? The responses to an outlier in the quality indicator performance should be actionable and involve planning and implementing for change and improvement. What is important here we should remember is you need not bring about dramatic changes in your system. Even small changes done in increments can achieve a lot over a period of time. So you may decide to continue monitoring, you may decide to stop monitoring that particular indicator, you may identify opportunities for improvement, you may bring in corrections, corrective actions based on root cause analysis. Again, a proper root cause analysis, I think most of us do not do a proper root cause analysis. Once you know the exact cause for that problem by asking the question why multiple times and arrive at the root cause, you target the root cause, you're going to plug that problem. So that is something we need to develop and develop an entire quality management strategy. You may need to modify the targets, modify the threshold. If we've been consistently achieving a target of 5%, you may want to tighten it and make it 3%. That takes your improvement levels to a higher strata. And then, if necessary, report to the appropriate parties, customers, accreditation bodies, public, and so on. So that needs to be decided. So the take-home message at this point is that quality indicators are an integral part of the quality management system with all the ISO requirements and the CLSI documents. Development of quality indicators should be based on both risk assessment of potential errors and the frequency of observed errors, and the risk of error and likelihood of harm is minimized using quality indicators. So if we follow a risk-based approach, our entire outcome is going to be safer to the patient. We are not going to cause harm, we are not going to cause injuries to the patient. So a risk-based approach to quality indicators makes the outcome more meaningful and safe. So this, my friends, is a very broad approach of how we need to rethink about the way in which we are defining and monitoring quality indicators and bring in the element of prioritizing your quality indicators based on the outcome, based on the risk, based on the harm or potential harm that we are likely to cause if we do not monitor those processes. So, thank you very much.
I thank you, doctor. So, any questions in the audience?
What is the difference of the quality indicators of the key performance indicators, the KPI?
KPI and
quality indicators is
I
the
think
same?
They should mean the same because quality indicator and a performance indicator, they both measure the same thing where whether you're achieving what you set out to achieve and is that achievement meeting your targets or not.
Yeah. And in the Mayo Clinic in Rochester, Minnesota, I have learned the quality system, and every 2 years they were reviewing every process to decrease, to improve these quality indicators showing the number of reject. Do you propose any certain time to improve every method in the lab to have better quality indicators?
I think it would not be wise to make a definite frequency with which these reviews need to happen. It all depends on the laboratory. Now, if a laboratory has developed a quality system and it's young, they may need to review these more frequently. Whereas a mature organization, they start reviewing it at less frequent intervals. But what is important is do not monitor these quality indicators just to provide some data for the assessment when the assessors come to look at your lab. Do it for your own benefit. Do it for the benefit of your patients. And that's where you realize that many quality indicators which you feel are not required, you just keep them aside. Take the more important ones.
And you use the Pareto rule to sort the problems, for example, for rejection of samples, to focus in the 20% of causes that produce the 80% of the rejections?
I think we could use a lot of these data.
Okay.
Statistically.
Thank you so much.
May I call upon stage the next speaker, Dr. Nitty Matthews. May I request Dr. Biren to chair the session, please?
Dr. Niti Matthews is a professional qualification is MD Pathology, and it is PhD cooperative major in medical photonics, and present designation is Associate Professor of Department of Transfusion Medicine and Immunohematology from the Christian Medical College, Vellore, Tamil Nadu, and he has over 13 publications on his name. And I would invite for the delivery his talk on acute febrile illness and WBC pattern. Please, Dr. Matthews.
Thank you for that kind introduction. And after that very important session on performance indicators, I'm going back a little bit to the WBC patterns. So basically we have, we know that there are a lot of different cell counters available that work on different principles, but we get, the outcome that we desire from every one of them mostly. So as we know, the Mindray system follows the SF cube with the 3D technology to decipher the information, whereas the other cell counters, for example, the Coulter has the VCS technology and the impedance principle. And other, just like the Mindray, you have the fluorescence platform on the Sysmex XN series, and then you have the Abbott LDT series of analyzers, which uses MAPS, that is multi-angle polarized scatter separation. And then there is the Horiba system where you have size and light loss on the other axis. So there are a whole lot of systems available that gives you a lot of information. So just taking you back to a very common scenario that we encounter in daily practice, a child with fever, or for that matter, anyone with fever. And then what stands out is maybe thrombocytopenia and some patterns that you can see on the cell counter. So I'll be dealing a lot with the patterns that we know and that we have found to be interesting. A lot of it will overlap with some that you have already heard, but then I'll just reiterate the points and, I can speed up the talk as well. So for example, this is, let's say, pattern 1, and you have 2 cases there where unfortunately, I think I do not have a pointer, but as you can see, you have a population in both of those cases, a population of cells below the lymphocyte population in the WBC scatter. So this is on the DXs, if you can recognize it. The other thing that you can note is that in the histogram of WBCs, the histogram doesn't start from the baseline. And then if you look at the cell population data, like Dr. Ramon was telling is very important, you can see that the dispersion of the lymphocytes and the monocytes are high. So this is the normal for comparison when you're expected to get these very well-defined populations and a proper histogram pattern and minimal standard deviation when you get that pattern. So what are we dealing with here? Basically, if you find 4 of these together, which is a population of cells below the lymphocyte population, the WBC histogram not starting from the baseline, and then you have an increase in the lymphocyte and the monocyte standard deviation put together, this is usually a case of malaria. Again, everything that I'm saying is in the context of an acute febrile illness. So to an experienced person or to an astute pathologist who has dealing with this a lot, you can even try to subspeciate the malaria. For example, if you find that the population below is a more thicker non-white cell population below the lymphocyte population, it's Plasmodium vivax. And if you find that the population is a little more dispersed and towards the y-axis, then it is probably a Plasmodium falciparum. Again, even on the other platforms, that was the VCS technology, even on the fluorescence platforms, you can pick up either what you can see as a pseudo-neutrophilia, or it could be a pseudo-eosinophilia as well. And on the lab use, only the research side, you can actually see that there's an extra population when you have the forward scatter versus the side fluorescence, where you shouldn't be having that population in the normal. So that was pattern 1. Now let's go to another pattern. This is pattern 2. So on the fluorescence flow cytometry platform, you can have on this on the the histogram, sorry, the scatter plot, you can have your normal populations here, and then you see a population of cells which has been spoken about a lot today, which is the HPC or the high HFC, the high fluorescence lymphocyte. This is the HFLC on the XN platform, and you can see this. But when you see this pattern, what are we talking about? So again, this, as we have identified, you can see this is a rocket trail pattern. You can see how the cells just shoot up, and you can see a bulge in the center, and as compared to the normal. And this pattern is usually seen in scrub typhus and I'm not going to the details of the statistics and all those things, but apart from the lymphocyte pattern, you can also see, being a rickettsial, that's the bacterial type of infection, you can also see that there is an activation of the neutrophils. If you look at, compared to the normal, the light blue population of neutrophils, you can see that there is a tilt of the neutrophil population to the left on the fluorescence axis. That's telling you that it is also very reactive, could contain Dolly bodies and so on. And in this particular one, you can actually see that there are some immature granulocytes as well. So that is because you have, apart from your reactive lymphocytes, you also have very activated neutrophils in the system. So if you go to the lab use parameters in a forward scatter versus a side fluorescence, you can actually see, compared to your normal, you have this golf club pattern because the neutrophil forward scatter is reduced. It could be because of increased membrane permeability and loss of contents because there's a permeating dye here. And then you can see that it pushes into the monocyte or the lymphocyte population, which are HFC. Therefore, it gives you this, this where you have your grip and your golf head, the club head, and you're giving you this golf club pattern seen in 87% of cases compared to your lesser number of controls. I'm not going to the details of statistics here, but the increase in the HFLC is seen in cases compared to controls, and we have a cutoff of more than 0.9. The SFL is increased in cases compared to controls, whereas the neutrophil forward scatter, which is the size, is actually reduced in the cases compared to the controls. Even on the DXH, on the Coulter platform, we have picked up certain patterns. So if this is the normal, we have seen that, as we explained in the previous slides, the neutrophils here again are activated. You can see that they have moved up. There could be a little left shift. Apart from that, you can also see that there is a merger of the lymphocyte and the monocyte population. And that's because of the activation of the lymphocytes, and the monocytes are merging. You can also see a shift of the neutrophils a little to the left, because when the size goes up, the scatter tends to reduce. And that you can also see, as compared to, you can see that these are actually evident in the cell population data as well, because there could be some subjectivity there, but we can make it a little objective by looking at the neutrophil volume, which is much increased in those cases. Similarly, the monocytes volume and standard deviation are much high as well. Another pattern, this has also been described by some of the previous speakers. So now, compared to the other one, here you see that there is a kink in the center. So compared to your normal in the lymphocyte, in the HFLC population, so you have your high fluorescence lymphocyte cells, but this time there is a kink in the center that is giving you a very reactive pattern. So you have your reactive lymphocytes giving you this figure of 8 or tilted hourglass pattern. So this one, you can see this consistently in cases of dengue, as was already mentioned. And just like HIV is a T lymphocyte-tropic virus, the dengue virus is a monocytotropic virus, and therefore you get activated monocytes as well, and sometimes that segregation capacity is lost, and you can get this kind of a pattern in addition to the reactive lymphocytes in the system. So on the Coulter platform as well, we can pick up certain findings. For example, you have the normal on the left and 2 dengue cases on the right. There you can see that the lymphocytes are a little more, there's a little more shift towards the y-axis, and the neutrophils haven't budged because there is no neutrophil activation in a case of dengue unless there is a secondary bacterial infection or sepsis setting in. So that is there, that we can again look at the cell population data. It's the monocytes which have been activated, the neutrophils remain as such. And you can also see this, what I'm showing at the bottom is the Abbott-Alnity H platform. So here there's no impedance, it's purely a polar, it's basically based on light scatter in different angles and polarized and depolarized light. So you have your lymphocytes, your monocytes, your neutrophils, and your eosinophils there. Now you can see, for example, in the bottom cases, you can see where this lymphocyte population is expected to be. You can see that in cases of dengue, there is a split in the population. And my technician in my lab pointed out to me and says, sir, I'm seeing a hard pattern. And I actually couldn't disagree. So yeah, that's there. So to see. So this is the pattern we see in dengue on this particular cell counter as well. So this was data published by work done by Anant Vikas while he was with us. And so for this dengue pattern, we have actually having an area under the curve of nearly 0.9, sensitivity of 82.8 and specificity of 87% at an HFLC cutoff of 1.35%. The other fact that I showed in the study was that the there's a sort of a mirror imaging between the platelet count and the HFLC. So the platelet count is at its lowest, the HFLC is at its highest. And there's been work done on this pattern even by Dr. Tina, as was mentioned in the first talk by Dr. Anil Handu. So yes, this is all out there in the public domain. And just to compare the normal versus a dengue and the scrub, even subjectively you can see certain differences, but they can make it more objective by looking at cell population data. And collectively you can actually look at the patterns and try to infer what kind of an acute febrile illness is lurking in the patient in the first sample that comes to the lab. So just before concluding, again, this is going to be a reiteration of a point which was shown very well by one of the morning sessions today. Basically, you have how an evolution of the HFLC, just a case study, because now it's actually a dengue season. We are getting a lot of cases along with Mansoor. Dr. Pradeep Suri had shown an interesting case. I'm going to show you probably exactly the same thing. So just one case, we have a professor of microbiology who had a history of fever for 2 days, vomiting 1 day, then developed headache and myalgia. So at baseline, these were the parameters. You can see that the total WBC count was 3,800, platelet count was 1,55,000. You have a neutrophil predominance at presentation, and on the same day sample, the next day, the dengue serology was reported as NS1 positive and suggestive of early dengue viral infection. Subsequently, we got the sample for this professor on every single day for the next 9 days. So this is the patterns that we have seen. So you can see on day 1, I've shown you the platelet count and the HFLC percentage at that point. This is exactly what Dr. Pradeep Suri was also pointing out today. You can see that in the first, how well defined the populations of the lymphocytes, monocytes, and neutrophils are. There is no HFC there, it's 0. In the second day, you can see that the monocyte starts dispersing there, but HFC is still 0, It's on day 4 that we can see that, and of course, the platelet counts are dropping bit by bit. It has become nearly 1 lakh on day 3. On day 4, the HFLC starts going up, the platelet count drops. The classical pattern you see is actually only from day 4, day 5, and so on. And then, of course, the platelet count dropped to 9,000. That's when the HFLC was at its peak between day 5 and day 6, almost 20 and 21. 12,000, 9,000 platelet count, and then the platelet count gradually increasing, 50,000, 8, 1,13,000, 4, 2,15,000, 2. So this was all just to show you the evolution of HFLC in this case of dengue, and to highlight the fact that you may not get the classical pattern that we talk about if they're present very early in the illness. So usually what happens is when somebody develops a fever, the natural tendency to use home remedies, take some over-the-counter medications and see if it will pass. And when only if it gets worse, they do present to us. So that's when we get them on maybe day 4, day 5, and then you might get to see the classical pattern. But in early dengue viral infection, very early presentation, you may not pick up that. So that is one point that we need to keep in mind. That's because, of course, I'm not going to dwell much on this because the NS1 is what comes up very early, and that's almost gone by day 2, day 3, day 4, and the IgM only gradually picks up. There could be an interim period where neither could be picked up on the screening tests. So that's that. Just putting the whole thing of that particular case in a tabular form. This is actually very recent. Just 6 September was the last date of documentation. And just to show you how the HFLC correlates with the platelet counts, and that the HFLC gradually increases, the platelet count drops, and then the HFLC can actually maybe predict platelet count increment over the few particular days. So that's all I have from this presentation, is just to say that patterns on different cell counters can actually help pick up a lot of infectious diseases if you look at the patterns very carefully. And we have to, of course, correlate with the clinical situation of the patient, and can help us in the early diagnosis of infectious diseases with the first CBC sample that comes to the lab. Thank you very much for your attention, and I thank my lab team, Dr. Sukesh, my technicians there, and particularly I would like to thank the organizers of CUBE for inviting me here. Thank you.
It was really excellent presentation with the help of the various platforms and role of this platform. Thank you. Now session is open for discussion. Any question, answer?
No, I would like that if you can come back to the slide of the dengue evaluation, because in the second day, in the day second, before the high fluorescent cells are positive, you can see the monocytes that are more dispersed in fluorescence.
Yes.
And that is what we have seen also in COVID and in other infections, that the monocytes are the predictor that will fall, the platelets will, and that is also, we can see clear what I mentioned in my presentation, that monocytes are more important than we think. And we need to follow them, or the morphology, because they can predict something, and it's the best that we can act before it happens something.
I see. Thank you.
You're welcome. And grateful presentation.
Thank you, sir.
May I call upon stage Dr. Sunita Sharma, and may I request Dr. Mamta Soni to chair the session, please.
Good evening, everyone. It's my privilege to introduce Dr. Sunita Sharma, who is a consultant pathologist with Wadia Hospital, Mumbai. She's a trained medical staff under IDSP, under DHS and UT Health Mission in 2018 and 2022. She had shared sessions among experts for expert comments in national level conference for PRBC, that is Pediatric Rare and Complex Benign Hematology Conference, on a case of congenital TTP held in Mumbai on June 2023. So I welcome you, Dr. Sunita, and over to you. Thank you.
Thank you, ma'am. And first of all, I would like to thank Mindray and the organizers for giving me the opportunity to present here. My study is based on a different kind of population. It's on newborns, mainly neonates. And this request came in the same PRBC conference. One of the neonatologists asked me, I need IT ratio. How can you report to me how I should send the request? Then I said, let me study. It should not be a big problem because we have hematology analyzers which has capacity to report so many parameters. But I asked some time from her, and then I started study, so that I thought, can I give the report to all the patients or only selective where requests are asked? So this is the study about the IT ratio, a predictor of septicemia in pediatric patients, and role of hematology analyzers. So I studied how much analyzers can help this kind of population. Since it is a pediatric hospital and a huge ICU, and ICU has a largest ICU in our hospital, 155 bedded, where 40 beds are ventilator assisted. So first of all, what is the septicemia? The definition wise, neonatal sepsis is described as a suspected or demonstrated infection in newborn, a systemic inflammatory response syndrome with variable sign and symptoms caused by pathogens with or without accompanying bacteremia. Neonatal sepsis is divided in two types: early onset within 72 hours and late onset, which manifests after 72 hours of birth. It's a leading cause of mortality and morbidity worldwide in middle and lower income countries. The overall mortality rate is up to 24.4%, but it can be as high as 30% and 54% in premature and very premature in infants. Neonatal sepsis incidence is 30 per 1,000 live births, whereas community-based studies indicate incidence as high as 2.7 to 17% of all live births. Septicemia risk factors are generally prematurity, premature rupture of membranes, low birth weight, birth asphyxia, congenital anomalies, etc. These various screening tests used for the diagnosis of sepsis are generally within 6 to 8 hours are WBC count, whether high or low, platelet counts, ESR, absolute neutrophil count, C-reactive protein, IT ratio, which I'm going to discuss, nitro-blue, tetrazolium test, serial interleukin 6, and procalcitonin. PLC low or high, immature to total neutrophil count is IT ratio, which cutoff is more than 0.2, which indicates the child is going to have septicemia. So for IT ratio calculation, we need hematology analyzer and the parameters related to neutrophil. How I compared this study is with the gold standard parameter, that is blood culture. Result of blood culture is available after 3 to 5 days and the accuracy varies between 8 to 73%. So IT ratio can give within a day or two that first day we get the sample of CBC, we can report that this particular child is going to have septicemia or not. So early diagnosis is a key. It helps to the pediatrician for timely antibiotic therapy and it also helps prevent emergence of resistant bacteria. Early decision can reduce infant mortality. Hence, the study was designed to test the diagnostic accuracy of IT ratio for early onset sepsis and its comparison with blood culture and other tests. This was a prospective study. I got the request in the June month and I did this in the July month for 1 month study. In a prospective study in neonates, generally it is found that high NP, negative predictive value of CRP and IT ratio in early and late onset infection is up to 90 to 98%. The sensitivity of IT ratio had ranged from 60 to 90% as per the literature. The elevated IT ratio values is considered in conjunction with other clinical signs for confirmation of neonatal sepsis. Few previous studies concluded that IT ratio more than 0.8 fairly approximates with the neutrophil storage pool in bone marrow, thereby saving the neonates for bone marrow examination. The ratio is quite helpful in identifying newborns who might be benefited with GCSF therapy. So our aim is, since it is a rapid, simple and readily available test, this study aimed to re-evaluate the usefulness of neutrophil left shift, immature granulocyte percent and IT ratio for the diagnosis of neonatal sepsis and assess its prognostic value. To calculate and establish IT ratio utility as an early onset sepsis predictor. To utilize hematology analyzer for the calculation of IT ratio and determination of cutoff as sepsis predictive marker, and to correlate IT ratio with culture study results, to correlate with the manual method, IT ratio calculation by machine versus manual. The parameters we took was IMG percent, shift to left and total neutrophil percent. The methodology what we used study was prospective observational study. Study duration was 1 month, July 2023. Inclusion criteria, the patients whose CBC count and blood culture sample we received were included and those one of them is not received were excluded. Sample size was 70. Results were recorded and analyzed as per MS Excel based software. Statistical analysis for the correlation was done. So method for IT ratio, as all knows, it's a percent of immature neutrophil divided by percent of total neutrophil, which includes mature plus immature. This formula can be fed easily in the LIS system and directly results can be given to every patient. Flags, we check the flags given by the machine as shift to left or IMG percent, and based on that we can decide for the manual count of peripheral smear for differential count, and then we calculate manually also. This is the flow chart which I followed. Blood culture request sent along with the CBC, then CBC was processed in the hematology analyzer. Analyzer flags were checked for IMG percent and shift to left, and based on that peripheral smear examination was done for manual DC. Here I did the manual DC because I wanted to compare from the machine versus manual. So for every case, manual smear was made. And formula was used to calculate machine value using IMG percent and manually differential count IMG plus total neutrophil count. This is the machine screen is showing shift to left and IMG percent, and in smear examination we saw the band cells which were not given in IMG percent by machine. So to calculate those band forms in immature granulocyte, manual count was required. Leukocyte counts were done on Mindray hematology cell counter in the lab. Differential including immature neutrophil count were performed manually after making suitable thin film smears by senior lab technician. IT ratio also calculated using IMG percent by machine. Only IMG percent divided by IMG percent plus neutrophil percent. That was machine count, and manually differential including band cell plus IMG, whatever immature granulocyte we get in the differential smear, in the peripheral smear, divided by total. The same time, inoculated blood cultures were incubated at 37 degree for 5 days. Negative culture reports given after 5 days. Positive flag culture bottles were subculture as per the SOP of microbiology. So we had 70 cases. Positive by culture were 22 and negative were 48. So average IT ratio manually, we are mainly concerned with the manual, but comparing machine. So IT ratio was going more than 0.245 plus minus 0.155, while by machine it was 0.03 plus minus 0.06. While in negative culture, manual method, you can see the value is very low, 0.096. And by machine, it is even lower, 0.025. And same time, I also analyzed CRP values, but CRP values were not available for all the patients, so data is lesser. 16 cases. Here, I just want to highlight that positive culture had high predictive value. 16 cases, blood culture positive. Out of them, 15 had CRP positive. I would like to show the tabulated form for a negative and positive culture with IT ratio and CRP values, and show other way. This specificity is for true positive is sensitivity is 63.6%. It's true positive, and specificity is 89.8%, around 90%. And the negative predictive value for IT ratio 0.2 is 84.3, quite high, it's quite significant. This is the graphical representation. Here we can see the culture positive and negative cases. In culture positive, IT ratio, you can see the cutoff is 0.2, and most of the culture positive cases, you can see the cases totally in the x-axis, they are all above 0.2. While for negative culture, IT ratio is below 0.2. This is by manual method. Then this is the machine method. Because machine bands are not counted in immature granulocyte percent, the cutoff value is very low. It is below 0.2, while for manual method, most of the cases showing cutoff value above 0.2. CRP values, we had very few cases CRP value available. We can see positive cultures showing, most of the positive are showing CRP value positive, while negative are showing low values, negative CRP. So the present study revealed that IT ratio showed high specificity, around 90%, and high negative predictive value, around 85%. This study depicts the role of low IT ratio as an indicator to exclude early onset neonatal sepsis. This is in agreement with the previous studies which displayed NPV in the range of 90 to 98% for IT ratio more than 0.2 in excluding early onset sepsis. This study counted only for neonatal sepsis, short duration of study, and tertiary Apex reference pediatric hospital with 155 bedded NICU. Present study revealed that even simple hematological ratio can help in ruling in or ruling out early onset sepsis, thereby decreasing hospital stay, alleviating the anxiety of parents, and help preventing development of antibiotic resistant pathogenic strains. This is especially important for various resource limited clinical setups. Total leukocyte count is not correlating with the positive culture for neonatal sepsis diagnosis, as majority of patients had normal counts. Automated calculation for hematology analyzers as sole interpretation should be avoided till further advancements are done. Till then, manual peripheral smear examination needs to be done. This is our study. Compared with other previous studies, the data are almost similar. So to conclude, IT ratio is a useful tool for early onset sepsis with reasonable specificity but cannot be relied upon as a sole indicator. Combination of normal IT ratio with negative CRP value in neonate is an indicator of non-infected neonate. IT ratio may be good alternative to blood cultures for neonatal sepsis as it is faster, less expensive, and has good sensitivity and specificity. IT ratio is a promise as a novel, effective, simple method to screen sepsis when used in conjunction with ANC and CRP and does not require special laboratory facilities. Further studies with improvement in method for detecting immature granulocyte and well-defined reference intervals are required in automated immature granulocyte persons. The limitation we found, we had only few infants with positive blood cultures. When calculating sensitivity and specificity, the new result is compared with the blood culture, a method which has its own limitation for both sensitivity and specificity. The study included material from a single tertiary care reference center. This increases the risk that the result only reflect the local situation. If analyzer counts band cells with IMG%, then formula can be fed in the LIS and reporting can be faster and error-free as manual counting variability can be minimized. Area of improvement and not limitation. The recommendation is to integrate the calculation formula of IT ratio in hematology analyzer through LIS for faster reporting of results for sepsis prediction. The machine needs to learn about the shift to left and IMG% better for direct calculation of IT ratio. These are the references. Thank you.
Thank you, Dr. Nita, for the lucid presentation. I just have one point to make here that we were depending more on the manual differential count by the senior technologists to calculate the IT ratio.
Yes,
the automation was not helping us much, right? Now, did you do anything to circumvent the inter-observer variation which happens, especially while counting the band cells? I mean, did you do an harmonization? Because there can be a lot of subjectivity. Some people may call the same band cell as neutrophil and some may call it as a band cell. So was there any attempt on that since it is a totally manual process?
Yes, there is a variability inter-observer. That's why the shift to left is the amount of band cells not given by the machine. If it gives, it can help much more because directly we can fed the formula also within the machine or in the LIS. And directly can be reported to all the pediatric population.
Yeah, so again, yes, so the automation will help in that.
Yes.
Fine. So, any questions? Yes, ma'am, please.
Thank you so much. Very nice work, very good presentation.
Thank you, ma'am.
I'm very glad that you brought out the problem of the analyzers in not recognizing band cells.
Yes.
Now, even Stanford Hospital, and we have been doing that. We manually count, they have also made a rule, slide review criteria for all neonates for diagnosis of sepsis. Because so far, none of the analyzers can measure band cells. They Myelo, Meta, Pro, yes.
Yes.
But band cells, they don't. And we have been doing also the same thing manually, but you are taking the negative predictive value as more important,
yes,
as ruling out sepsis.
Yes.
We have been working on the positive aspect of it. What we do is, of course, manual band cell to neutrophil ratio, but we have added eosinopenia to that formula. And if you start looking at that, you will realize even your analyzer will give you either no eosinophil or very low eosinophil, 0.01, 0.02. Start looking at that. You will see, you will be able to predict sepsis.
Yes.
Instead of saying no sepsis, you will be able to predict sepsis, but only on band cell neutrophil ratio. And I look at the eosinophils along with it. But I'm very glad you brought this out. I've been talking to all the analyzers. कि आपकी machine band cell क्यों नहीं count करती? They can't do it because it is basically neutrophil only. That's it. Thank you so much.
Yes, ma'am. And the band, even shift to left was given only for 3 patients here.
Yeah, and in a busy lab, it is actually whenever we get a request from the pediatrician to calculate a band neutrophil ratio, we hate it because it is so time consuming and it is also a lot of inter-observer variation. Yeah.
Though it's a helpful parameter for septicemia diagnosis.
Yes, yes. So yeah, food for thought for Mindray. Give us band cells. Yes, sir, please.
No, I have to say my opinion about bands because when I go to the international meetings or the ICSH and they treat me like crazy when I say that bands are useful. But I have to be objective. I have done studies with sepsis in neonatal sepsis, including bands or not, only immature neutrophils. And when you include the bands, the ROC curve and the sensitivity increase dramatically. And are the facts. I cannot go against the facts. And the fact that bands statistically are better to be included or not. And they say, but they have a lot of variation. Yes, but metamyelocytes have a lot of variation between also observers in the microscope. And they are in less proportion. For this reason, even with a low number, have more variability between, for this reason, but there is a fashion. And of course, no any company can go against the 95% of the laboratories in the world that they don't report bands, they don't give bands. But honestly, my opinion is bands are useful.
Yes, yeah, even RCPA morphology and bone marrow program, it doesn't differentiate band. You can give band plus neutrophil together.
But I have a good news. Yeah. The MC80 include bands. Yeah, so the MC80, the digital imaging include bands.
So thank you, Dr. Raman. Any other question, comment? If not, thank you, Dr. Sunita, for a very informative and detailed presentation.
May I call upon Dr. Shreya PB, our next speaker. May I request Dr. Anil Handu to chair Dr. Shreya's session, please.
He is a fellow currently at the prestigious Christian Medical College, Vellore, and she has done her pathology, MD pathology from Thrissur, and currently she'll be presenting to us about her work which she's done on analyzers for myelodysplastic syndromes. The stage is yours, ma'am.
Thank you, sir. First of all, I would like to thank the organizers and my faculty in CMC Vellore for giving me this opportunity to present my short study in this venue of CUBE 2023. So without further, I am going directly into my short study, which is differentiation of aplastic anemia from myelodysplastic syndrome using cell population data analysis on automated hematology analyzer. So proper distinction of etiology of pancytopenia can often be challenging. Two main differential diagnoses for peripheral blood pancytopenia are aplastic anemia and myelodysplastic syndrome, presently called as myelodysplastic neoplasms. Myelodysplastic syndrome is usually characterized by hypercellular marrow with features of dysplasia in one or more lineages. However, in 10 to 15% cases of MDS, marrow is hypocellular. So this can pose a diagnostic challenge from aplastic anemia in the marrow. So the most commonly accepted method for assessment of dysplasia is microscopic examination of peripheral smear as well as bone marrow. Peripheral smear in the RBC can show macrocytosis. In the bone marrow, it can show ring sideroblast. Neutrophils can show hypogranulation, hypolobulation, pseudopelga-Huey anomalies. Monocytes are hypogranular, often with nuclei or nuclei containing nucleoli. Giant platelets can be seen. Circulating blasts are seen in the cases where MDS with IB1 or IB2 is suspected. Micromegakaryocytes or fragments of micromegakaryocytes also can be seen in the peripheral smear. But the usual problem with the peripheral smear is there is lack of reproducibility between the different observers. There is a technical problem and time of smear making after drawing the blood and the quality of the stain. All these can affect peripheral smear. So assessment of dysplasia is very often subjective. So cell population data analysis is a more objective way to assess dysplasia. Aim of my study was to utilize cell population data from automated hematology analyzer to assess morphological alterations of red blood cells, white blood cells and platelets to objectively identify dysplasia in myelodysplastic syndrome and to differentiate it from aplastic anemia. So automated hematology analyzers, as various speakers have spoken, utilizes different principles like light scatter, electrical impedance, fluorescent light absorption, and electrical conductivity. Our own department has a study which found out that, as everybody else here knows, that conductivity or the granular light scatter is reduced in myelodysplastic syndrome when this was compared with the healthy controls. Mine was a retrospective study where we took 51 cases of aplastic anemia and 28 cases of myelodysplastic syndrome, wherein peripheral smear was also done along with the bone marrow examination, and we had access to the peripheral blood count. Peripheral blood samples were collected in EDTA and it was run in retic mode and WPC mode. Along with this patient sample, we also took 120 normal controls. MDS was made according to the WHO classification. Aplastic anemia was classified according to the severity of various cytopenias. These are various morphological features we usually get in the marrow, like dyserythropoiesis, pelga-Huey nucleoli, micromegakaryocytes or exploded megakaryocytes. And coming to the results, among the WBC parameters, we analyzed 13 indices and we found that side scatter and side fluorescence was significant between the two groups. MDS had a significantly lower side scatter of 141 compared to aplastic anemia, and it was also lower than the reference population. Side fluorescence was higher in aplastic anemia when compared to MDS, but it fell within the reference range. This is the plot showing neutrophil side scatter and side fluorescence. Among the RBC and platelet parameters, we didn't find any significant platelet parameters, whereas among RBC parameters, fragmented RBC and reticulocyte index in the y-axis, which is the side fluorescence of reticulocyte index, were significantly different. The fluorescence of reticulocytes were higher in aplastic anemia, whereas it was lower in MDS. But the fragmented RBCs were higher in MDS when compared to aplastic anemia. So we postulated that it might be because of the macrocytosis. Higher incidence of fragmented red cells, we thought that it could be due to macrocytosis accompanying the MDS. So these are the RBC indices which were significant between the two groups, reticulocyte size in the y-axis and the fragmented red cell. We also did the ROC curve and found out the sensitivity and specificity of all these parameters. We found that FRC and RET-Y had the best area under the curve of 0.839 and 0.833 respectively. FRC had a sensitivity of 85% and specificity of 80%. RET-Y had a sensitivity of 82%, specificity of 73% to differentiate between aplastic anemia and myelodysplastic syndrome. Neutrophil SFL and SSC had a sensitivity of 85 and specificity of 76%, whereas side scatter had a sensitivity of 75%, specificity of 84% respectively. So we concluded that cell population data analysis, that is decreased neutrophil side scatter and side fluorescence compared to aplastic anemia, can differentiate in the cell blood counter itself, which may be due to hypogranularity of the neutrophils. FRC was significantly higher, which may be due to coexisting macrocytosis. So cell population data parameters showed promise in differentiating myelodysplastic syndrome from aplastic anemia with good sensitivity and specificity. Thank you.
Thank you, Shreya, for that very lucid talk, yet in the shortest possible span of time that you could have done. One question before I set the ball rolling for the rest of the people to pitch in. Did you, from the data that you've shown, I obviously know that probably that's not the case, but just wanted to confirm from you, would you have done some megaloblastic anemia cases at the same time with this study? And, or have you done that, as a separate part?
We haven't done megaloblastic along with this. We didn't take any megaloblastic anemia cases. We excluded those cases, sir.
Okay. Yeah. My hunch is that if you do megaloblastic anemia cases, there might be a challenge between the MDS part of it, not the aplasia part of it, but the MDS part of it vis-a-vis the megaloblastic itself. There might be an overlap between your findings. That's my hunch. I will not be, unless we do it, will not be sure.
May I request Dr. Dhanani, may I request Dr. Anil Handu to chair the session, please?
It's my proud privilege to invite Dr. Manani on the stage, and he'll be talking about the role of leukocyte research use only parameters in suspecting and monitoring sepsis. He has more than 15 years of teaching experience and has about 8 publications in national and international journals. And he's currently the lab director and zonal head for Arogyam Sterling Acaris Laboratory, South Gujarat. Dr. Hiren Danani, all yours.
Thank you, Mindray BLK Max Hospital, for inviting me. Thank you, Kshama, for giving me the responsibility of batting in slog overs. So, believe me, I won't take much time. My topic of discussion is role of leukocyte research parameters in suspecting and monitoring sepsis. Now, I won't go into the detail of the clinical aspect of sepsis progression, but the boxes placed above this slide represents progression of sepsis in a nutshell. In our study, we took clinically suspected cases of sepsis with positive blood culture by Bactec and PCT above 2 nanogram per ml. So total 334 patients met the criteria and we enrolled them in our study group. As a control group, we enrolled 466 subjects who came for comprehensive health check with all other biochemical and immunological parameters within normal range. Now, this is Mindray SF 3D cube graphics, already been covered by various speakers. We did our study in BC68 Plus series instrument, and it gives value of X, Y, Z coordinate for lymphocytes, monocytes, and neutrophils. We know that neutrophils and monocytes are the first line of defense. So in sepsis, changes in their size, shape, internal complexity, as well as nucleic acid content do take place. The neutrophils show increased phagocytic activity, cytokine production is increased, suppression of their apoptosis along with increased release of newer neutrophils from bone marrow. Changes in monocyte also take place during sepsis as mentioned by previous speakers. Basically, all these factors contribute to clusters of neutrophils and monocytes which are placed slightly differently in 3D cube than the normal counterpart, altering X, Y, and Z coordinates slightly. And precisely that is what we wanted to study along with other reportable parameters. Now we used a variety of statistical tools to analyze our results, and one of them was receiver operating characteristic or ROC curve with calculated area under curve. We all know that range of AUC is between 0 and 1, 1 being perfect classifier. So when we analyze the 9 position parameter, we found that nu Y has got the best correlation followed by mono X, mono Y, nu X, and then nu Z. The mono Z and all 3 lymphocytic parameters did not show significant correlation. When we further analyzed, the finding of ROC, AUC were confirmed on further statistical analysis. Here we can see in this box and whisker plot the demarcation between control and sepsis group. In the lower box, we can see the mean values of each of these parameters. One thing we can notice that in sepsis, the standard deviation for most of or each of these parameters markedly increased, suggesting marked inter-patient variation. The p-value were quite significant, way less than 0.05 for each of these parameters. Now, based on Yoden index, the optimal cutoff for each of the parameters to suspect sepsis was decided. And based on that, sensitivity, specificity, positive predictive value and negative predictive value were calculated. Now, for example, since nu Y we got the highest correlation at the cutoff of 4 to 8, nu Y alone could have diagnosed 266 out of 334 cases of sepsis, but at the same time, 92 cases from the control group also been diagnosed as sepsis. So 92 false positive. The sensitivity and specificity for nu Y was in the zone of 80%. The rest of the parameter showed sensitivity and specificity from 57 to 75%. We also evaluated few routine WBC parameters. We selected total leukocyte count, absolute eosinophil count, as we know that in sepsis, eosinophilia is a known phenomenon, even in adult also. Immature granulocyte count, which is also a reportable parameter, and neutrophil lymphocytic ratio to include both neutrophilic and lymphocytic representation. As we can see from ROC curve, NLR was the best correlating parameter, better than all the CPDs, followed by IMG, then total leukocyte count and absolute eosinophil count. Again, the findings of ROC curve were confirmed on further statistical analysis, and all the parameters showed high degree of correlation between case and control group with p-value way less than 0.05. The cutoff for each of these parameters again decided based on Jordan index. The NLR, for example, was the best correlating parameter, and at cutoff of 3.25 was a very good marker to differentiate between these two groups. At 3.25, it could detect 308 cases of sepsis, while 34 cases from the control group also showed positivity. Now, this particular slide summarizes all performance of all the parameters in a single bar chart. NLR and IMG were clearly most correlating parameter, followed by nu Y, total leukocyte count, then mono X eosinopenia, and mono Y, nu X, and nu Z were the least correlating parameter out of 9 studied. Now, though NLR was the most correlating parameter, it had quite a few false positives and false negatives. So we thought of somehow integrating these parameters and see whether we can increase sensitivity and specificity further. And for that, we did multivariate logistic regression analysis or logic model. It is a non-linear statistical analysis used to classify into 2 different groups. That is in present study whether sepsis is present or not. The output is always between 0 and 1, 0 being likelihood of disease nearly 0% and 1 being chances of disease highest. We call them sepsis prediction score or SPS model, and permutation and combination of various WBC reportable and research parameters were carried out. In this particular slide, 3 different SPS models are shown out of many we evaluated. In SPS1 model, we combined only reportable parameter and we got improved result with area under curve of 0.989. In SPS2 model, we integrated all 5 WBC position parameters which were statistically significant, and again we got improved area under curve of 0.950, better than individual parameters. In the third SPS model, we used a combination of reportable and research parameter. We used 5 most correlating parameter and we got the area under curve of 0.997. But the best correlation was found when we combined all 9 parameters and look at the ROC curve, which gave us area under curve of 0.999, means a perfect classifier. At the cutoff of 0.5, this particular model could detect 330 out of 334 cases of sepsis, and at the same time only 4 false positives. So sensitivity was 98%, while specificity was almost 99%, with positive and negative predictive value close to 99%. This bar chart shows that the calculated SPS was a clear winner amongst all parameters we studied. Now, we assessed the utility of SPS in some of our cases. This particular patient is our regular patient who is a known case of CLPD, got septicemia due to Klebsiella pneumoniae. He was admitted on 21st of January in ICU for sepsis. The upper 4 rows represent his hematology data from his prior visits to our lab. Lower 2 rows show his follow-up data after getting discharged. His PCT and CRP levels were very high during his period of hospitalization. When we applied the SPS calculation on all his data, this was the result. As we can see, SPS score was always above 0.5 during the period of hospitalization, and then gradually decreased, and in follow-up, it was below 0.5. This is another example of a case where 63-year-old male patient got admitted on 19th December. This table shows his clinical progress as well as CBC finding during his visit, during his hospitalization. The first row show the result of his clinical data almost a year back. So we can consider it as a baseline data. Then he got admitted for sepsis on 19 December last year, got shifted to ward on 27 December as his clinical condition improved. He remained admitted till 12th of January this year for dialysis and for the treatment of acute renal injury. Again, when SPS calculation was applied, we can see that for the initial period of sepsis, SPS remained pretty high and then started falling gradually, returning to baseline, and then never went up, even during his period of hospitalization and for the treatment of dialysis. This is the last case, third case of a 57-year-old male patient who got admitted with small bowel infarction and then progressed into septic shock, unfortunately succumbing on 23rd of January. Here also his PCT levels were pretty high and he was admitted in ICU. In this also, when we did SPS calculation, during his ICU stay, the score was clearly above 0.5. But still, I would say a lot of work needs to be done, and more deeper and robust analysis is needed before a parameter like this can be included in research or as a flag. So my message from the study is, it is nearly impossible to comprehend data from modern day, what modern day cell analyzers are throwing at us. And in fact, we may not be doing justice with the technology, as subtle changes in values may often go unnoticed. So use of data science, AI-based model in objective analysis can definitely help us, as well as clinician in patient management. It is always better to combine the parameters to negate the false positives and false negatives associated with individual parameters. With that, I conclude my presentation. Thank you.
With improvement in this.
Yes, sir, definitely. So it helped us in monitoring also. These were the few cases out of 356 or 344 cases that we studied. And definitely, when we combine all the parameters, the sensitivity, specificity is always improved. In fact, I wanted to show a few cases of CML also, where this SPS, this particular model failed, because in all CML cases, the score was nearly 1. But when we applied that particular model, which included only cell population data, and that worked wonderfully well. Without sepsis. Just CML. Because obviously the total count that we included, NLR that we included, and IMG that we included were clearly above here. Yes. But then when cell population data of those 5 significant parameters, when we applied that model, that worked perfectly well.
Very interesting, very nice
presentation. Yes. Thank you.
Appreciate it.
That's really compelling data. In fact, something to take back and probably work on.
Yes.
We'll also try to work on this and see how it pans out in our center as well.
Yes, sir, but then combining multiple parameters will always be very helpful.
Yeah. Thank you. That was really nice presentation. Anybody else has any questions? I guess no further questions. Thank you very much.
Thank you, sir.